that are going on Congenital Heart Academy. And today it ended up to be a very, very special day. Dr. Jatene, who is Brazilian, as myself, was supposed to turn 91 years old today if he was still with us. So this is a special day because by chance, other things that are going on Congenital Heart Academy. And today it ended up to be a very, very special day. Dr. Jatene, who is Brazilian, as myself, was supposed to turn 91 years old today if he was still with us. So this is a special day because by chance, other things that are going on Congenital Heart Academy. And today it ended up to be a very, very special day. Dr.
Do you have echo, guys? I'm listening a big echo.
Supposed to turn
it's turning, yes.
Years old today if he was still with us. So this is a special day because
I mute.
It's repeating. It's repeating.
Yeah. Okay. Now I think it's normal, right?
Yes, I think
okay. So just to tell you that. So it was something that it was very beautiful, especially for us from Brazil. And with the Department of Congenital Heart Diseases of the Brazilian Societies of Cardiology, we decided that today is going to be a beautiful day that we could dedicate to the memory of Dr. Jatene. And we want to invite all the societies, especially for us around the world, to join us on something that we want to start today as the TGA Day. So we hope that this day will be remembered every year as a day that we could talk a lot and learn more about TGA in the memory of Dr. Jatene. And we are very happy to have Marcelo Jatene, who is the son of Dr. Adib, to speak more about this today. Very good. And another thing that I want to tell you is about the Congenital Heart Academy delegates. So we want to have people from all around the world to help us to spread the news. We want Congenital Heart Academy to reach every country, every place, so people can help us to diffuse our voice. So what we want people to learn, and we want them to share their experiences and the local experiences that are amazing as well. So we are very happy. We have already all of these countries represented with us. And if your country is not read yet, please send us an email. We want you to join us and bring your expertise, your skills, your country's experience, and you're going to help us to get the information being delivered in the places that it should be. And just to finalize, we want to give you a save the date. So every Thursday at the same time, we are preparing very nice webinars for you. So we intend to continue to have every Thursday, at least until July, one meeting. So please save the date. So the next one's going to be cardiac anesthesia. And we are going to have another activity this Monday that is going to be about clinical cardiogenetics. It's going to be very, very interesting. So next Monday at 3 European time. So please follow us on the social medias, then you can have all the information about the meetings that we are preparing. Thank you very much for that. And now I want to start our very special meeting that we are dedicating to Dr. Jatene with Dr. Anderson. Dr. Anderson doesn't need any introduction, but now he is a visiting professor fellow at Newcastle University, and he's going to talk about the truth is beauty and beauty is truth, about the morphology of transposition. Welcome, and thank you very much, Dr. Anderson.
Yes. So the topic we will discuss today has been controversial for well over a century. The picture you're seeing here is the first example we are aware of this specific lesion, which is the drawing made by Matthew Bailey in 1796. And he had no problem when he first saw the lesion. He simply called it a singular anomaly. In the time that has passed, we have come to realize that the essence of the lesion is the presence of discordant ventricular arterial connections. So what do we mean by that? We mean that rather than rising from morphologically left ventricle, the aorta takes its origin from the right ventricle or from its rudiment, and also the pulmonary trunk takes its origin from the left ventricle or its rudiment. The potential problem with this definition, however, is that this specific ventricular arterial connection can be found with various atrioventricular connections. And that is why I have emphasized the aorta can arise either from the morphologically right ventricle or from its rudiment. So when we look at the other atrioventricular connections, most frequently we see discordant ventricular arterial connections with concordant atrioventricular connections. And it is this combination that will be the topic of our discussion today. But the discordant ventricular arterial connections can also be found when the atrioventricular connections are discordant. And then the two discordances cancel each other out. We can also find discordant ventricular arterial connections when there are isomeric atrial appendages, the arrangement often called heterotaxy, nowadays much better split up into its two constituent parts, left isomerism, right isomerism. And in the setting of right isomerism, it is frequent to find situation of discordant ventricular arterial connections, but then because of the isomeric appendages, the atrioventricular connections are mixed. We can find discordant ventricular arterial connections with double inlet ventricle, particularly double inlet left ventricle. And indeed, it is double inlet left ventricle with discordant ventricular arterial connections that is the commonest variant. And we can also find discordant ventricular arterial connections when one atrioventricular connection is absent, as we see quite frequently with tricuspid atresia. But as I've already said, the combination we are going to be considering today is that of concordant atrioventricular and discordant ventricular arterial connections. And since this is the most frequent combination, it is my opinion now we should take this as the default option. And in that respect, we can simply call the combination transposition. And then we can use specific descriptions for those other combinations, such as the double discordant combination, which of course is congenitally corrected transposition. But today, we are going to concentrate on concordant atrioventricular and discordant ventricular arterial connections. So let's see what happens to the circulation when we have these two connections. I'm showing you the arrangement at the moment in which the morphologically right atrium is to the right side, and the blood coming back from the morphologically right atrium goes into the morphologically right ventricle because the atrioventricular connections are concordant. But then, because the aorta is arising from the morphologically right ventricle, the blood is running in parallel rather than in series. And that is the problem with this combination. So on the other side, the pulmonary venous return coming back to the morphologically left atrium goes through the morphologically left ventricle, but then is pumped back to the lungs. And this, of course, is the combination that we see with usual atrial arrangement. But it will be immediately obvious that we can have exactly the same combination, albeit very much rarer, when everything is mirror imaged. So when the morphologically right atrium is left-sided, as in mirror imaged arrangement, with concordant atrioventricular connections, the morphologically right ventricle is similarly left-sided, and we have left-handed ventricular topology. And then when we have transposition in this setting, the aorta receiving the blood from the morphologically right ventricle, but pumping it back into the systemic circulation is left-sided. And so when we have the mirror image derangement, the morphologically left atrium is obviously right-sided, as is the morphologically left ventricle, and so is the pulmonary trunk. But once again, because of the combination concordant atrioventricular, discordant ventricular arterial connections, the circulations are running in parallel rather than in series, and that is the root of the problem. Often nowadays we hear this combination called D-transposition, but that gives me problems because I've already illustrated to you that the combination we've seen is not always associated with a right-sided aorta. Indeed, when we have transposition with concordant atrioventricular connection,
Sasha, you think to unmute? I think you need to unmute. We can't hear Dr. Anderson anymore.
When, as I've shown you, we have transposition in the setting of mirror image derangement in Van Praaghian terminology, transposition ILL, then neither do we have a D-loop, nor do we have a right-sided aorta. So in this combination, there is no question but that it is inappropriate to call this D-transposition. And it would also be inappropriate to call it L-transposition, because in most circumstances, L-transposition is considered to represent congenitally corrected transposition, but that is also less than perfect. So although they are popular, I suggest these shorthand terms, D and L transposition, are inaccurate, potentially misleading, the more so when for the default option, we can simply talk about transposition. So what are the variables we find when we have concordant atrioventricular connections and discordant ventricular arterial connections? Well, you will all have appreciated by now that one of the most significant variations is the relationship between the arterial trunks. So in most instances, we find an anterior and right-sided aorta, but that is not always the case. And indeed, on very rare occasions, the aorta may not even be anterior. So it is the connections that underscore the problems. Infundibular morphology is also not constant. So in most instances, there is infundibulum in right ventricle. There is fibrous continuity between the pulmonary valve and the mitral valve in the left ventricle. But again, this is not constant. And on occasion, we can have bilateral infundibulums. On exceedingly rare occasions, we can have aortic to mitral fibrous continuity. Much more important, however, are the associated malformations. And it is these associated malformations that complicate the arrangements of concordant atrioventricular, discordant ventricular arterial connections. Perhaps the most important is deficient ventricular septation, but added to that, we must consider obstruction of the outflow from the morphologically left ventricle. So how do we take care of these associated malformations? In my opinion, we analyze and describe them just as we would had they been present in the setting of concordant atrioventricular connections and concordant ventricular arterial connections. So here I'm showing you the possibilities for the ventricular septal defect when the aorta arises from the morphologically right ventricle, the pulmonary trunk from the morphologically left ventricle, discordant ventricular arterial connections. And in most instances, the defect will be perimembranous. And the phenotypic feature of perimembranous defect, as in the setting of concordant ventricular arterial connections, will be fibrous continuity between the leaflets of the mitral and tricuspid valves. But in the setting of transposition, it is the pulmonary valve that is, in most instances, also in fibrous continuity with the atrioventricular valves. One of the frequent features in the setting of transposition, however, is malalignment between the muscular outlet septum and the remainder of the muscular ventricular septum. We can have muscular defects anywhere within the ventricular septum, and then very rarely we can have the third type of ventricular septal defect, that which is characterized by fibrous continuity between the leaflets of the arterial valves, making a defect doubly committed and juxta-arterial. And as is the case in the setting of concordant ventricular arterial connections, this type of defect most frequently has a muscular posterior inferior rim, but it can extend to become perimembranous. So what about the substrates for obstruction from the left ventricular outflow tract? In the setting of discordant ventricular arterial connections, it is, of course, the pulmonary route that is supported by the morphologically left ventricle. But any of the lesions which, in a heart with concordant ventricular arterial connections, can produce aortic obstruction, will produce pulmonary stenosis in the setting of transposition. So we may find that the stenosis is present at valvar level. More problematic is when there is a ventricular septal defect and the outlet septum, be it muscular or fibrous, is deviated to obstruct the outflow from the left ventricle. This is the combination that underscores the Rastelli procedure, nowadays the Mikaido or the Rev procedures. So a particularly important combination. But we can also have bulging of the ventricular septum, either with deficient ventricular septation or when there is a ventricular septal defect made worse by a fibrous shelf. We can also have tissue tags which blow through from the high pressure right ventricle, and on rare occasions there can be abnormal attachments of the valvular tension apparatus. So ventricular septal defects, left ventricular outflow tract obstruction, these are the lesions which most frequently make transposition complex rather than simple, which is the way we describe it when the ventricular septum is intact. The other thing we have to take into account, however, are the coronary arteries. And there are many ways and many classifications that have been devised to describe the arrangements of the coronary arteries. In my opinion, the multiple ways the coronary arteries can be arranged are so great that no simple or Procrustean classification can cope for all the variations. So it is my preference to use a descriptive approach, and we need to take care of sinusal origin, most importantly. Of course, relative to the arterial pedicles, do the arteries run behind the pulmonary trunk, or is there an artery running in front, the aortic outflow tract from the right ventricle? Of particular importance is when the arteries take an intramural course, one or other of the major arteries running between the arterial trunks. It's also important to take note of accessory arteries, or indeed to note when one of the major arteries may be absent. And nowadays, we're beginning to take account also of commissure mismatch. But most important is the sinusal origin of the coronary arteries. And if we look at this picture of our heart with transposition viewed from above, there we see the aorta, which in this instance is indeed anterior and right-sided. The feature of coronary arteries is that almost without exception, they take their origin from the two sinuses of the aortic root that are adjacent to the pulmonary trunk. I am aware of only one or two examples throughout the world ever being described in which a coronary artery arises from the non-adjacent aortic sinus, but we must bear that in mind. But to all intents and purposes, we can think of the arteries arising from these two adjacent sinuses. So if we are to describe the variations, we need to distinguish between these sinuses. And in my opinion, that is best done on the basis of the so-called Leiden convention. And that relates the sinuses to the way they are seen as the surgeon considering himself or herself as a mannequin standing in an non-adjacent sinus, looking towards the pulmonary trunk, judges the two sinuses adjacent to the trunk as being either to right hand, sinus to the right hand is considered number one, and in most instances that gives rise to the main stem of the left coronary artery, which then branches to give rise to the circumflex and the anterior interventricular arteries. If one of the sinuses is to the right hand, then of necessity, the other sinus will be to the left hand. And we distinguish that as sinus number 2. And in the commonest variant, this gives rise to the right coronary artery. And this usual arrangement where the left main stem, the circumflex, the anterior interventricular arteries come from sinus 1, right coronary artery from sinus 2. This is found in 2/3 of most cases when there is intact ventricular septum and almost 2/3 with ventricular septum defect. But anything is possible. And indeed, we now must take account that very rarely a coronary artery may arise from a non-adjacent sinus. But if we describe sinusal origin, we then account for the course of these arteries relative to either the pulmonary trunk or the aorta, and we describe everything descriptively, we can take care of all those variations, taking particular note of the intramural variations. What is commissural mismatch? That is found when the commissure of the pulmonary trunk is not opposite the commissure of the aorta, and that increases the distance between one of the coronary arteries and the sinus of the pulmonary trunk into which it will be transferred to produce the neo-aorta. And that is now coming to the fore as another of the possible variants. So if I put everything together, to me now, transposition is simplified as the default option for discordant ventricular arterial connections in the setting of concordant atrioventricular connections. And then, if we take care of all the associated malformations, we account VSD, left ventricular outflow tract obstruction, remembering that we now need also to describe the varying arterial relationships in fundibular morphology, and in my opinion, transposition becomes very simple to describe and also to understand.
Grace.
Yes, very nice. Thank you very much, Dr. Anderson. It was amazing. We have a couple of questions that I think we can answer them on the break that we are going to have soon. So now, Dr. Gil Wernovsky, our co-founder, and
my slides up, team?
Yes.
And they're in the presentation mode, is that correct?
Yes, perfect.
It's coming. Yeah, now it's coming.
Okay, I'll start. We're learning about this process, everyone, and apologize for little glitches in the audio that we're hearing. We're also learning how to use the answer questions live function in our chat box, so please bear with us for that. The Academy has been absolutely, let me just see if I can advance that. There we go. The Academy has been really an amazing example of how we can learn internationally. On behalf of Jeff Jacobs, who I know is on the call, and is a co-chair with me for the 8th World Congress of Pediatric Cardiology and Cardiac Surgery, I encourage you to write down these dates as this will be occurring in about 16 months now, I think, which is a little bit concerning. But one of the things that we are learning is that without question, we need a streaming option for the World Congress, in addition to hoping that we all get together, whoever can come to Washington, D.C. So we're learning a lot from this. In your course evaluations, please let us know how you think this is going. So in a relatively short amount of time, I am going to talk about some pretty complicated physiology, talk a little bit about the circulatory effects of prostaglandin, how we as intensivists and inpatient docs can get the baby set up best for cardiac surgery. So one of the unique things about transposition physiology is it can be distinguished from either single ventricle physiology or a normal series circulation, in that it is the only situation in the human where the pulmonary artery oxygen saturation is higher than that of the aorta. We also use the term for this, which I think is correct, about a parallel circulation rather than in series. For the purposes of this presentation, I'm going to use these box diagrams where on your left is the systemic circulation, starting with the systemic venous return through the right atrium, right ventricle, and then systemic blood flow from the aorta. And on your right, the pulmonary venous return, left atrium, left ventricle, and pulmonary artery. And in this situation, and you can see here where the labels are, in this situation, the venous return comes into the atrium and then goes back and is recirculated to the body. So if we look at the so-called parallel circulation, after the baby is born and separated from the placenta, in the absence of any communication between these circuits, we end up with very congested lungs, but a very hypoxemic baby, as shown here on the left. So over short periods of time, and the physiologic mechanisms that manage this and keep this going are a little bit unclear, but the amount of blood that goes from the blue side to the pink side needs to be exactly the same as what goes from the pink side to the blue side. Otherwise, and I'll show you an example of this, one circuit will completely fill up and the other one would be empty. So that's over short periods of time, over minutes to hours. However, because pulmonary vascular resistance falls, eventually we start seeing more blood going from the systemic side to the pulmonary side, just as we see in structurally normal hearts. And over time, there is increasing amounts of pulmonary blood flow. Eventually, the pulmonary blood flow, shown on the left as QP, becomes significantly greater than the systemic blood flow. The pulmonary circulation and the left ventricle become volume overloaded. We end up with an X-ray that looks like that in the upper left-hand corner of cardiomegaly, increased pulmonary vascular markings, and I guess you could call that an egg on side. And I had the opportunity to learn much of this from a cardiologist named Milton Paul. Milton was a cardiologist at what was called Children's Memorial at the time, which is now Lurie Children's Hospital in Chicago, and spent really the early part of his career detailing this physiology in days when the only way we could investigate it was with cardiac catheterization. And this is one of the figures that he used to explain this to me, and is in a chapter we wrote a number of years ago together, looking at the mixing between these two circulations. And over time, when you catheterize children at an average of about 2 to 3 months after birth, the pulmonary blood flow is roughly twice that of the systemic blood flow, but with a significant amount of variability. We're going to get to some other parts about this in just a second. I don't know with the bandwidth whether this type of circulation is coming through appropriately or not, but what I've tried to show here is the red blood cells on the pulmonary side and the desaturated blue cells on the systemic side that happens after birth. But fortunately, many babies will have a PFO or even a naturally occurring atrial septal defect. And as we talked about before, there's equal volume of mixing in both directions across that atrial hole. So in a baby that has just atrial level shunting and the volume of blood from one side to the other is exactly equal in both directions, we actually have a pretty stable circulation where we have atrial mixing alone. There's no significant volume load early on to either side. There's no symptomatic congestive heart failure. There is significant hypoxemia. So it's not uncommon that we have a very happy baby, but very unhappy doctors and nurses, especially now that we can see a pulse oximetry rating, range of about 60 or 65%. And as Dr. Seed, I'm sure we'll talk about, that's probably better than they were in utero. However, in our current day and age, because we have the technology to treat this, what normally will happen, I'm sure in most of your institutions, is the recommendation to start prostaglandin. So once prostaglandin gets started, and I'll give you a sort of cartoon evaluation like that at the bottom, there will be a connection between the aorta and the pulmonary artery, shown there as a blue arrow with a red line around it. And the volume that goes from blue to pink will be equal to the volume that goes from pink to blue in the atrium. We can show that here. Again, trying to circulate the red blood cells here, what ends up happening now is we have a left to right atrial shunt and an aorta to pulmonary artery shunt. The oxygen saturation is, quote, better. I hear that term frequently. But we now have a heart that's volume overloaded and eventually a baby that will develop heart failure from a large ductus arteriosus. This is some data on the left that we took from the bedside monitor of a baby where the baby had low oxygen saturations, and on the bottom line is the oxygen saturation. The middle three lines are the systolic mean and diastolic blood pressure, and the top line is heart rate. The decision was made to start prostaglandin, and you could see on the purple line right about where the ductus opened there and got the oxygen saturations up to about 90%. That made some people happy. The pulse pressure going along with an open ductus began to widen, and the heart rate slowly began to increase. So the cost, so to speak, of a higher oxygen saturation is the potential for congestive heart failure, a wide pulse pressure, tachycardia, perhaps abnormal flow to the brain, and hopefully Mike will touch base a little bit on this postnatally. And as we see in the premature infant, and why we're asked to close ductuses frequently, is because of the systemic steal, organ oxygen delivery may be decreased even though the pulse oximetry reading is increased. And I think we need to study this just a bit more. Personally, in the ICU, I love to see kids whose heart rates come down and blood pressures go up. And for that reason, I am generally more tolerant of lower oxygen saturations in transposition. But I have to say, most intensivists do not like to stop prostaglandin. And there's a lot of discussion, as you might imagine, in our intensive care unit, as well as probably all of yours. I find this to be inversely proportional to age. Another thing I hear in the intensive care unit is the baby is stable on a prostaglandin infusion, and that's the big myth. The baby is not stable on prostaglandin. The reality is the baby is going to go into heart failure on a prostaglandin infusion. And I've heard people say prostaglandin is bad because it gives tissue edema and all that stuff. Actually, what is not good physiology is a wide open ductus arteriosus, especially in diastole. There could be low cerebral oxygen delivery and gut oxygen delivery. Many surgeons have told me that there's tissue friability when a baby's on prostin for a while. It's probably not the prostin, but the fluid retention due to heart failure. But prostaglandin can also have its problems with hypotension, apnea, fever, and rashes. So let's talk about the one situation that I think we worry about the most, and that's the patients with intact atrial septum. They're hypoxemic. They get started on a ductus arteriosus, which results in an aorta to pulmonary artery shunt, as you could see here at the bottom. But then as this blood returns to the left atrium, there's nowhere for it to go. And the patients end up with profound acidosis, profound hypoxemia, and shock. And it's not because the prostaglandin is bad or the ductus shouldn't be open, but because there's no way to get the red blood from the pulmonary veins to the aorta. And we've probably all seen cases like this, where the X-ray is highly congested. It could be obstructed total pulmonary veins or mitral atresia. It's all the same physiology. You need to get red blood from the pulmonary veins to the aorta. And we don't have many options as an intensivist to deal with this. The only way to really get this any better, in my opinion, is to call on Lee Benson and his colleagues in the cath lab and say, we need an open atrial septum as soon as possible. In the meantime, and I'll share this toward the end, there are a couple of things that we can do to make the baby as stable as possible before the atrial hole is made. How do we think about dealing with persistent hypoxemia despite a good atrial septostomy or prior to the atrial septostomy? Well, we have these options. We can put a baby on ECMO, we can put a baby on bypass and do the arterial switch. But one other way to think about this is to think about, hold on, I'm just going to check my timer real quickly, is to think about what we could do on the mixed venous side. So again, this is a picture that we had put together in our book chapter a long while ago, where I showed you the QP to QS ratio. But this is yet another example where using the term ratio is not helpful at all, because what we want to know about in this disease is the effective pulmonary blood flow. What do we mean by effective pulmonary blood flow? Well, first of all, you could see it's only a fraction of the total pulmonary blood flow, usually in the range of about a quarter. If we try to get an idea of the way this looks from at least a figure perspective, if we imagine that our systemic on the left and pulmonary on the right blood flow is circulating around and around and around, none of that blood contributes to gas exchange. It's only the red blood that gets to the systemic side that delivers oxygen. And it's only the blue blood that gets to the pulmonary side that eliminates CO2. So those red and blue arrows are what we would call the effective flow. And the QP effective, or the effective pulmonary blood flow, is the portion of the total pulmonary blood flow that contributes to gas exchange at the capillary level. Increasing flow in and of itself may not help us. We have to increase effective flow. The majority of the total flow is ineffective, as you can see here. And similarly, because we know those numbers are exactly the same, the systemic blood flow that's effective is only the blood that gets from the pulmonary veins to the aorta. The majority of it is ineffective. So what can we do as intensivists? Well, what we can do is we can make that blue blood, the ineffective blood, as pink as possible, meaning we have to increase the mixed venous oxygen saturation. This is the only tool we have in the intensive care unit. And the only way we can increase the mixed venous oxygen saturation is to decrease the consumption of oxygen peripherally or increase the delivery of oxygen from the myocardium. And we're all familiar with those ways, which would include decreasing consumption, avoiding fever, sedation. Tell your neonatologist, please, or if there's any neonatologists on here, we've gotten far away from using neuromuscular blockade in preemies, but single doses of neuromuscular blockade can reduce oxygen consumption by at least 20%. And you can get another 5 to 10 points in oxygen saturation. We have tried inotropic support and transfusion. But again, the only thing that really matters is you don't mix from the ductus. More prostin doesn't help. You need an atrial hole. The only way to get these babies stable is to get blood from the left atrium to the aorta. And I hope that's your takeaway from this talk, that we can try a lot of these maneuvers, but really the only thing that we can do is you have to have an atrial level shunt. Even in babies with transposition VSD, blood does not like to go uphill from the low resistance LV into the high resistance systemic circulation. The last thing I'll mention about this is the fear I have of stroke in these babies. And Lee may mention this talking about the atrial septostomies, but any systemic, any vein has the potential of putting gas or particulate matter into the systemic circulation, which then can go to the brain. So some of you may see this potential problem here in a series of IVs. The nurses do the best they can to get rid of these things, but these little air bubbles or particulate things can go right from vein to brain. As we talked about, the majority of the blood flow is recirculated. So leaving a baby with transposition physiology is not a good idea. Transposition is surgical heart disease. An open PDA is not necessarily a good thing. It's probably bad for you. We like to keep kids on Prostin. In fact, we were having a discussion about a case this morning at my own institution about the timing of a baby that was born yesterday who's, quote, doing well on Prostin, should we let him recover? So I'm going to quote my good friend and colleague, John Berger, who I've had the pleasure to work with for 2.5 years now. And he has said, you cannot treat surgical heart disease with medicine. Remember that transposition physiology is tricky, it's unpredictable, and it's potentially dangerous. However, an arterial switch operation is good. It takes blue blood to the brain and makes it red blood. And as I've shown at the wonderful meeting in Taormina last year, it can take a blue Dr. Agati and make him into a pink Dr. Sasha Agati. I think that's all the time that I have, and I'm happy to answer any questions through the chat room. Thank you.
Thank you, Gil. Of course, thanks to make me pink. And we go to the next presentation. As you say, we need Dr. Benson, who is a staff interventional cardiologist from Sick Children Hospital in Toronto. If you stop to share your screen, Gil, we can ask to.
Oh, my bad, sorry.
Yes, we can ask to. Yes. If Lee, if you want to share your screen, is the moment.
Yes. Can you see?
Yes, very well. Thank you.
Okay.
Yes.
So I'd like to thank the Congenital Heart Academy for the kind invitation to talk about balloon atrial septostomy. I like to speak initially in a historical context. This is really the first true clinically applicable interventional procedure, now 55 years old, as described by Dr. Rashkin in his landmark 1966 paper, which is the technique very effective in relieving hypoxia and decreasing oxygen requirements. On the bottom left side is a line diagram from one of his early papers describing the technique. Importantly, the chart next to it is a life table from the Hospital for Sick Children taken in the late 60s, early 70s, defining the impact of balloon septostomy on the life of a child with transposition, demonstrating that by doing a balloon septostomy alone, it allowed the child to survive, as opposed to the natural history of the disease. And this was important because Mustard's operation, the atrial switch operation at the time, was best performed when the child was 6 months of age. So it was important to do some maneuver that would improve oxygenation and survival. The Blalock-Hanlon operation in the 1950s was around, but it had a high mortality, and it was a technically difficult operation for the surgeons. I remember speaking with Dr. Rashkin some 40 years ago about how he came out deciding to perform or to describe this way of creating an atrial defect. And he told me that in his reading of Dr. Tausig's Congenital Malformations of the Heart textbook, he was inspired by the clinical observation that she had made that transposition with an atrial defect had a much longer lifespan than those without. So what are the indications for an atrial septostomy? Gil sort of laid the groundwork for the physiologic basics. It's a class 1 indication to enhance atrial mixing. The physiologies was well described. The procedure itself, the equipment, there's now 2 balloon septostomy catheters available that can be used. Access site is from the femoral or umbilical vein. this is an old picture, but it describes the technique that's done. It's very unusual now to have to take the patient to the cardiac catheterization laboratory to actually do the procedure. Today, inevitably, it's done at the child's bedside in the intensive care unit under echo guidance. And it's performed by a single jerky motion. I remember Dr. Raskin telling us that it really requires 2 jerks, one holding the end of the catheter. Dr. Raskin is a very funny guy. It's not risk-free. There are risks and complications: balloon rupture, air getting into the circulation, as alluded to by Gil, embolization of balloon fragments, which is very unusual, as is the rare event of the inability to deflate the balloon, misjudgment of the position of the balloon in the atrial septum, cardiac perforation, particularly if there's juxtaposed atrial appendages, an issue that is less evident today under echo guidance, and of course mitral valve injury. There can be vascular injury, as you can imagine, in the pulmonary vein. The femoral artery can actually be damaged. These babies are very hypoxic, and cannulation of a femoral vessel, one may think they're in the vein when they're in the artery, and the placement of a large sheath can traumatize the vessel. And of course, there's the risk of avulsion or tear of the IVC with a very aggressive pullback of the device. And there are higher complications rates documented if the procedure is performed out of hours, usually because these children are very, very ill and unstable. And then finally, embolic complications such as stroke may be encountered. And this clearly has impact on neurodevelopment of the child and has generated a great deal of controversy about the use of balloon atrial septostomy. So I just want to go over some of the data about stroke with this procedure. Now, one of the original articles from Quinlan and Steve Miller talking about the risk of stroke in a group of patients with transposition. They looked at 29 newborns with preoperative MRIs and found 41% or 12 patients having a stroke. These were pre-op ischemic strokes. They were focal, they were in multiple locations, and they were with various combinations of wall motion abnormalities. All of these patients had balloon atrial septostomies, but there were some confounding variables. All had low systemic oxygenation, and they were unable to identify any effect of the axis site. For example, a clot, if you were doing an umbilical venous cannulation and the ductus venosus was closed and had a thrombus in it. They couldn't find a pattern of global hypoxia on the MRI scans, and they had no effect of the degree of neonatal illness severity accounting for the observations on the MRI. The most recent review of this kind of lesion is this April from Hamza from a registry data base looking at 1,700 babies with transposition over a 16-year period, a quarter of them having balloon atrial septostomy. The mortality with those having a septostomy versus those not having a septostomy was the same, although there was a higher mortality and a need for ECMO in patients who had no septostomy performed. And they did observe a higher incidence of clinical stroke in 1.1% of the balloon atrial septostomy patients, but they were unable from the database, the registry database, to identify the timing of the stroke. The patients with who required a septostomy were in hospital a bit longer, perhaps reflecting that these patients were more profoundly hypoxemic and were unstable going into their surgery. and therefore accounted in part for their long hospital stay. Another paper that I thought was of interest was from New Zealand and Australia. And these authors looked at 44 babies before surgery with preoperative MRIs, but they were unable to identify any association between septostomy and brain injury, whether that be white matter injury or stroke. They did identify white matter injury in 30% of the patients with septostomies, but also 18% of the patients without, and a very low incidence of stroke in the population, and no risk factors for injury identified, either the route of balloon atrial septostomy, illness severity, the degree of hypoxia or oxygen delivery. I put that little video up in the corner. As an interventional cardiologist, I'm trying to be unbiased, but I do remember when you go to a barber, you do get a haircut. So it's try to be a level playing field. The last paper I just want to mention from CHOP, I think Gil was the third author on this paper. Chris Pettit looked at 26 patients with transposition, again, preoperative MRIs, half going and having undertaken a balloon atrial septostomy. No strokes were observed. 10 were found to have hypoxic brain injury in the form of white matter injury, or what was termed periventricular leukomalacia, but it was not associated with balloon atrial septostomies. What was observed, which was interesting, was that the neonates with the lowest preoperative saturation and the longest preoperative desaturation had the highest incidence of white matter injury. And they also observed that the longer times to surgery were also associated with brain injury. Again, something that was alluded to in Gil's description. So what can we say about the decision to perform a balloon atrial septostomy? Taking the patient population, unrestricted ASD, preductal saturations, say 80, 85%. If the baby is intubated, extubate the child and look for a trial of prostaglandins and to see if they maintain a reasonable oxygen saturation. What the patient who presents with a restrictive ASD, you can call that a 2 or 3 millimeter defect, very arbitrary. A mean Doppler gradient greater than 4 or 5 millimeters, arbitrary. Low preductal sats on prostaglandins. I guess if the patient is acidotic, much more motivating to perform the procedure. If they're not acidotic, sometimes there's a conversation about the appropriateness of creating an atrial defect. We don't take that standard. We intubate the babies, paralyze them, and perform the procedure. However, with the therapeutic goal of reducing the time of having a low systemic saturation. But there are some caveats. If the child is intubated and paralyzed, sometimes it's very difficult to make the decision because their oxygen saturations can improve dramatically, again, as alluded to by Gil, with the maneuvers in the unit. And there is a certain institutional preference which impacts the decision-making. The timing to the operating room, and I think Mike will address part of this, the timing of to the operating room. If it's going to be in 2 or 3 days, maybe there's no imperative to perform a procedure. But if it's going to be in a week, or there's the possibility that may be delayed, it can become an issue in management. And then there's the desire to stop the prostaglandins, to avoid the complications while on an open ward, perhaps, apnea, fever, GI issues, the impact on clotting, tissue edema due to the medication, a lower diastolic blood pressure, all of which affect the physiology of the child. And then finally, it's as you follow a large number of patients through with transposition who are placed on prostaglandins and then have a septostomy, about a third of these babies will require reinstitution of the prostaglandins because of falling saturations. And this may be due to a low left atrial pressure, pulmonary hypertension and the fact that the prostaglandins has a certain pulmonary vasodilator impact. There may be a gender impact, genetic impact, and of course, there's been some observation on the duration of the use of prostaglandins before the septostomy is performed. So in summary, balloon atrial septostomy creates a non-restrictive atrial communication, optimizing atrial level mixing, improving systemic oxygen saturation, PO2, cardiac output, and lowers the left atrial pressure. The technique is the single most important factor in improving survival in babies with transposition prior to surgical correction. The predominance of evidence would suggest that the most profoundly hypoxic babies who have a balloon atrial septostomy are indeed the ones who are at the highest risk of brain white matter injury. And the mechanisms of these injuries are complex: inflammation, hypoxia, ischemia, brain maturity, etc. And as such, improvement in the degree of hypoxia may, in fact, reduce the risk of a white matter injury and better the neurodevelopmental milestones of the children. So with that, thank you very much.
Gil, are you there, or you answer to the chat?
A lot of very interesting questions on the chat and on the question and answers as well.
Gil is not there, so we will go. We go to the next speaker again from CKids from Toronto. The colleague Mike is a very. It means one of the last paper coming from his center, and he will talk us about the optimal timing of the arterial switch. Thank you, Mike. If you can share your.
Hi, Mike. Before you pick up your slides, as you might imagine, there's been a ton of questions about timing in the chat. So I think this is going to be very timely, no pun intended, timely talk for the multiple questions that I've tried to answer in the chat. And Lee, thanks for your talk. The one comment I'd also want to make is there's so many other ways besides the septostomy that kids can have stroke. And maybe we can talk about that in the Q&A.
Yes.
Well, hello. Thank you I'd like to start by thanking the organizers for this opportunity to talk about the timing of the arterial switch operation. I don't have any disclosures except to say that the question of when the arterial switch should be done is not one our group has ever set out to answer. Rather, it's an issue that has become a subject of interest during our research into neurodevelopmental outcomes in patients with transposition. And so I'd like to start by showing you the results of our study of brain injury and perioperative brain growth in patients undergoing an arterial switch at our hospital over recent years, and then circle back to the broader question of what the optimal timing might be for performing the operation. We used pre- and post-operative brain MRI and neurodevelopmental testing at 18 months to look for clinical risk factors for adverse developmental outcomes in 45 infants with transposition with or without a VSD. On preoperative imaging, we observed similar findings to those that have been reported by prior studies, including evidence of brain injury in a third of our babies. The majority of these were white matter injuries, like the one shown in A. However, about 10% of our patients had a small stroke, like the one shown in the thalamus in B. Several patients had intraventricular hemorrhage, like the one shown in D. And most patients did not show any progression of brain injury on postoperative imaging, although one baby that developed sinus thrombosis secondary to a neckline clot developed seizures and had evidence of venous infarction in both thalami, as shown in C. We assessed brain growth by measuring brain volume using MRI. which we converted to brain weight Z-scores based on reference autopsy data. Most of the patients showed a slowing of brain growth between the pre and post-operative scan. While we didn't identify any clinical risk factors for pre or post-operative brain injury, we found 2 risk factors for impaired perioperative brain growth, which were the presence of a ventricular septal defect and older age at surgery. The latter is illustrated by this plot of post-operative brain size Z-score and against age at repair. In Toronto, we've traditionally delayed the arterial switch operation by 6 to 8 weeks in patients with a large VSD and reasonable oxygen saturations. And this is reflected by this plot showing the number of patients operated by age. As you can see, there's an early peak at 6 to 7 days, mostly consisting of patients with transposition with intact septum, while patients operated later often had VSDs. Based on this distribution, we divided the patients into an early group operated in the first 2 weeks and a late group operated at more than 2 weeks of age. These plots compare brain weight Z-score on the post-operative scan in the early and late groups and in the intact septum versus ventricular septal defect groups, illustrating the more significant deficit in brain growth in patients undergoing later repair and in those with a VSD. One possible explanation for impaired preoperative brain growth in babies with transposition is arterial desaturation. Cerebral blood flow can be measured with phase contrast MRI, and in newborns with a range of cyanotic congenital heart malformations, including 13 babies with transposition, we found that although cerebral blood flow was preserved compared with normal controls, cyanosis resulted in a reduction in cerebral oxygen delivery. Another factor that may play a role in impaired brain growth in infants with transposition is pulmonary overcirculation. Patients with unrepaired TGA with open ducts and large interatrial communications typically have shunts in the 3 to 1 range, but may have shunts as high as 6 to 1. And while even in the face of very high pulmonary blood flow, cerebral autoregulation seems to preserve cerebral blood flow, there's clearly an effect on blood flow to the lower body, which presumably affects gut perfusion. And so feed intolerance and the resulting poor nutrition may have an impact on brain growth. As you can see, blood flow to the lower body normalizes following repair. Similarly, brain growth trajectory also picks up following repair. The neurodevelopmental test results from our study revealed scores within the normal range in all of our subjects. However, the scores were all lower for the late repair group, and we found negative associations between language score and age at surgery, as shown by the plot on the right, as well as language score and days of open chest. Length of stay was also negatively associated with cognitive outcome. Our results are in keeping with the findings of the Boston circulatory arrest study, in which the transposition patients with VSDs who were repaired on average 11 days later than those with intact ventricular septum had more evidence of brain injury on perioperative EEG and postoperative neurologic testing and early neurodevelopment testing. Interestingly, these early markers of neurologic abnormality translated into cognitive impairments when these children were older, which were most significant in patients with a combination of a VSD and circulatory arrest. Another transposition cohort, this time from New York, that underwent a battery of psychological testing in early adulthood, revealed a similar degree of mild neurocognitive impairment and anxiety. In this study, the presence of a VSD was actually protective against depressive symptoms in adulthood, while older age at surgery was one of several factors that was associated with poorer neurodevelopmental outcomes and mental health issues. It would appear then that earlier surgery may be neuroprotective in patients with transposition. But what is the impact of timing of surgery on overall outcomes? Well, the answer to that question likely depends on era. It's worth considering how far we've come since the early days of the arterial switch, when mortality was more than 20% at centres that were starting to perform the operation, as was elegantly shown by Catherine Bull and her colleagues at Great Ormond Street. Subsequent data from the same centre shows that 20 years ago, arterial switches were often performed much later than they are today, and with very good results. Although patients were more likely to die or require ECMO for a deconditioned left ventricle when operated after 28 days of age. By 2004, centres like the Cleveland Clinic were reporting excellent survival for the arterial switch, which was generally being performed in the first 2 weeks in patients with transposition with an intact ventricular septum. Patients with more complex anatomy were being repaired later, also with very low mortality, although about 25% were needing re-intervention. By 2014, many centres, including Columbia, were reporting large series with mortality of less than 2%, and homing in on the relationship between timing of surgery and the perioperative morbidity and the cost of care. This data suggests that the sweet spot for the arterial switch operation in patients with transposition with or without a VSD is around 3 days of age. However, this study from Michigan looking at outcomes in patients needing neonatal surgery for either single ventricle palliation or obstructed pulmonary blood flow, as well as arterial switch operations, showed that younger age of surgery was actually associated with higher mortality in newborns requiring a systemic to pulmonary artery shunt, with a similar trend for transposition. So in contrast with the results reported by Columbia, older age surgery did not negatively impact perioperative morbidity. Recent data from the Pediatric Health Information Systems database for more than 2,000 infants undergoing the arterial switch at 40 North American centers revealed there's still some variation in the median age at arterial switch, although most centers are performing the operation during the first 10 days. High volume centers tend to do their switches earlier, and this is associated with a small survival advantage, although other factors like prematurity in the presence of a genetic syndrome are more important determinants of outcome. So to summarize, outcomes following the arterial switch are now spectacularly good, and when the ventricular septum is intact, the operation is usually done in the first 10 days. There seem then to be two distinct approaches when there's a large VSD. While some centers operate early, as they would for transposition with intact septum, others prefer to delay the surgery for a few weeks. While there may be valid surgical reasons for delaying definitive repair, our impression is that this may have an impact on neurodevelopment through a combination of ischemic injuries and impaired brain growth, probably as a result of excessive pulmonary blood flow and or cerebral hypoxemia. And to emphasize this point, I'd just like to leave you with this normal growth chart, which shows how, in contrast with somatic growth, which continues steadily for 18 years or more, the first few months of life are associated with a very rapid period of brain growth, such that in normal children, 75% of adult brain mass has been achieved by the age of 2. So it's perhaps not surprising that brain development may be particularly susceptible to disruption as a result of the abnormal cardiovascular physiology associated with unrepaired transposition. In the middle is data published by Jane Newberger in the New England Journal of Medicine in 1984, showing the relationship between age at atrial switch and IQ in children with transposition, which shows so clearly what a positive impact timely surgical repair has on neurodevelopmental outcomes. And so I'd like to finish by thanking you all for your attention and expressing what a great honor it is for me to be representing Sick Kids, where Bill Mustard was our chief of cardiac surgery from 1957 to 1976.
Gil?
Thank you very much, Mike. It's really my pleasure to introduce a longtime friend. I don't like to say old friends anymore, Meryl, but a longtime friend and superb pediatric cardiologist at Children's Hospital of Philadelphia. She's held many titles, director of the Echo Lab and director of the fellowship program. And I'm really glad that she'll be sharing her thoughts with us today on preoperative imaging. Thanks, Meryl.
Can you see my slides, Gil?
Yes.
Yes.
Okay. Okay. I want to thank Sasha and Grace and Gil for inviting me to this extraordinary session. It's remarkable to see how many people are on this webinar, and I'm very pleased to be a part of it. So I'm going to talk to you about imaging. And as you heard from Professor Anderson, transposition is a ventricular arterial assignment. It is also, as you heard from Gil, a physiologic state. And we're talking today about patients who have atrioventricular concordance with ventricular arterial discordance. And then if you have situs solidus, that's a D-looped heart, if you're using Venn Prognian terms, and mirror image, the L-looped heart. And we do distinguish between simple and complex transposition in that in the simple form, you have generally an intact ventricular septum or very small VSD. And in complex form, you have large, malaligned or multiple ventricular septal defects. And we know, and you're going to hear about some of the surgeries that are performed, the arterial switch with or without the Lecomte in patients who have an intact ventricular septum or small VSDs. The Rastelli or the Nakaido procedure is performed when there is a posterior malalignment ventricular septal defect in association with pulmonary outflow tract obstruction. And then in the patient who has an anterior malalignment VSD, there is a very complex repair that includes the arterial switch operation. And then, of course, in patients who have late diagnosis, we may choose to perform an atrial switch in that venue. Of course, we want to know all the information about the patient prior to surgery, but I want to highlight specific areas particular to transposition of the great arteries. And this is, of course, the atrial communication, as you've heard about, the atrioventricular valves. We'll talk about the VSD, the type, the size, and the number, infundibular morphology, outflow tract obstruction, aortic and pulmonary artery relationship, and then arch and patent ductus arteriosus, and then, of course, coronary artery anatomy. In 2016, we put out a multimodality guideline for transposition of the great arteries, and this is just a list of the various views we use in order to make determination of various aspects of the anatomy. And what I can say is that echocardiography is generally the only modality required for pre-surgical evaluation. And so in that protocol, we particularly in our institution start in the subxiphoid view. And here's a list of the variety of things that we can see using this view, including particularly the atrial septum and diagnosing juxtaposition of the atrial appendages if it exists. We can often tell VSD type. We can enumerate the aorta to pulmonary artery relationship and assess infundibular anatomy. The apical view, of course, for ventricular size and function and AV valve function and anatomy. We can also see the outflow tracts by sweeping anteriorly as well as semilunar valve function. Some people start in the parasternal view, and we can also use that to assess assigning the great arteries, as well as see the parallel relationship that we typically see in association with transposition of the great arteries. And then AV valves and infundibular anatomy. The high parasternal view is used to assess the coronary anatomy And then, of course, suprasternal for arch and ductus arteriosus. And transposition is what I would say an instantaneous diagnosis. You can make one sweep of the heart and know that the patient indeed has transposition. And here you see a subxiphoid sweep, and you can do this either in subxiphoid or parasternal long axis view. And you can instantly see the atrial septum and know if the atrial communication is large enough. You can assign or see the assignment of the pulmonary artery to the right ventricle here, and then the aorta arising anteriorly assigned, pulmonary artery to the left ventricle and the aorta to the right ventricle. It also helps us assess the orientation of the great arteries. Here you see the pulmonary artery is posterior and to the left of the aorta, and we can even get hints about the coronary arteries. And in general, in transposition of the great arteries with intact ventricular septum, you see this very parallel circulation of the great arteries, which you can see in almost any subxiphoid view. If you do start with parasternal long axis view, the diagnosis can also be made very quickly. The great arteries are seen diving posteriorly in parallel, and this is also an excellent view to assess the left ventricular outflow tract, which often has obstruction. In the apical view, we can highlight the inflows, we can assess the semilunar valves. Again, you can see the relationship of the aorta and the pulmonary artery. Here you see the pulmonary artery arising from the left ventricle, the aorta from the right ventricle. You can assess ventricular performance, and we can even get hints about abnormal coronary artery patterns. Restrictive atrial communications can be identified quite quickly by transthoracic echocardiography. Usually we know quite quickly that there's a problem because the PO2 is quite low in these patients, and this can help usher the patient to get a balloon atrial septostomy. I will tell you that it can occasionally be tricky to tell if there's an atrial communication or not. Here's a recent patient of ours who actually had no atrial communication whatsoever. This was an aneurysm of the septum primum, and so the atrial septum was being pushed from the flow from the left atrium, but in fact there was no crossing over of flow, and the patient still required a atrial septostomy. An atrial septostomy can be performed at the bedside. The advantages of that is no radiation. You don't have to move the patient from the intensive care unit. And here you see the balloon across at the left atrium, and then you sort of lose it for a second and see it pop up again on the right atrial side. And then you can very quickly determine if the atrial septostomy has been effective. This can all be done in the subxiphoid view under the drapes as the catheterization is being performed in the ICU. Professor Anderson touched upon ventricular septal defects in the setting of transposition, and they are similar to the types of ventricular septal defects we see in patients with normally related great arteries. About 40 to 45% of children with transposition have a ventricular septal defect, and it can be any of these types: perimembranous, outlet with malalignment. Inlet defects are pretty unusual except in isomerism, and then muscular defects. And then of course, if there is malalignment of the infundibular septum with the ventricular septum, we will see outflow tract obstruction in those settings. So ventricular septal defects add complexity to the surgery and often have a higher rate of reintervention. And patients who have malalignment type VSDs, that will often dictate the type of surgery that is performed. One thing I really do want to emphasize is that we often perform echocardiography within the first hour after a baby with transposition is born, either because we know the prenatal diagnosis or because they are cyanotic. And in those instances when the pulmonary vascular resistance is still high, there's limited shunting. And so VSDs can be missed if you only echo the patient very soon after their birth, particularly perimembranous defects and muscular defects. And here's an example of a perimembranous VSD. You can see in the subxiphoid view here and the parasternal long axis view here that the direction of flow is from the right ventricle into the pulmonary artery. Again, I want to emphasize that it can be missed early on. And so I would suggest that any patient who is imaged in the first few hours of life should have imaging again prior to surgery, either in the operating room with transesophageal imaging or just a glance at the ventricular septum again before they go to the operating room. As Professor Anderson mentioned, an outlet or juxta-arterial ventricular septal defect where the infundibular septum is hypoplastic or absent is somewhat unusual in this setting, but here you see this very fibrous rim between the two great arteries. You can see that the aorta and the pulmonary valve are at the same level. And the reason why it is important to know this is because the surgeon may approach it differently. And because there is not muscle between the two outflows, the surgery can damage the semilunar valves in trying to close the VSDs. With posterior malalignment VSD, the infundibular septum is directed towards the left ventricle. And in this particular cohort of patients, the aorta tends to be anterior to the pulmonary artery. Here you see the infundibular septum, and this orange is the ventricular septum, so it shows you that relationship. If the pulmonary outflow tract is small, these patients usually cannot undergo an arterial switch operation. And so the echocardiogram is required to assess the severity of pulmonary obstruction. But keep in mind, if the ductus arteriosus is wide open or it's early on, the patient may have no gradient across the pulmonary outflow right away. We use sort of the pulmonary annulus size as a surrogate to tell us if there's going to be obstruction. We can assess the size of the ventricular septal defect and determine if the patient is a candidate for Rastelli or Nakaido. And here you see this infundibular septum tipped into the left ventricular outflow tract, and you can see it here as well. You can see the mitral to pulmonary continuity here, fibrous continuity, and you can see that the pulmonary outflow in this setting is quite small compared to the aortic. With anterior malalignment, the infundibular septum tends to be directed rightward, which you can see here in green. So again, here's the ventricular septum and here's the infundibular septum in this relationship. And in this setting, the aorta tends to be more side by side with the pulmonary artery. These patients can undergo a complex arterial switch operation, which may require an arch repair if the aorta is small, if the patient has coarctation or interruption of the aortic arch. And in some cases, the aortic outflow is so small that they may require a right ventricular outflow tract augmentation at the time of the arterial switch, similar to patients who have tetralogy of Fallot. So again, we need to assess the severity of the aortic outflow obstruction, which includes the size of the aortic annulus and the subaortic region, and then arch must always be assessed. Here is a subxiphoid view where you see that the infundibular septum has become an RV structure from this malalignment. You can see the side-by-side great arteries, and the aorta is smaller than the pulmonary artery. And here in this apical 5-chamber view is another example. Infundibular septum is malaligned. The aorta and pulmonary artery are in parallel. Professor Anderson discussed the variations of pulmonary outflow tract obstructions, and then the limits of time. I'm not going to go through all of them, but you can see a variety of ways that you can have that obstruction here. And echocardiography can essentially diagnose all of them. Here is an example of a mitral valve attachment to the ventricular septum causing obstruction to the pulmonary artery. Here's an example of tricuspid valve aneurysmal tissue in the way of the pulmonary outflow. And here you see a subpulmonary ridge in the parasternal long axis view. Professor Anderson also described the alignment of the commissures of the aorta and the pulmonary artery. And you can see that typically they are in alignment, as you see here. However, sometimes they are misaligned, and again, that may affect the ability of the surgeon to transfer the coronaries because it takes a longer distance to get there. These are recognized in the high parasternal view. That view is also used to help us assess great artery position. You can have the aorta anterior and to the right of the pulmonary artery, which is the most common relationship we see of these great arteries. They can be side by side. And if the great arteries are side by side, you're more likely to see coronary artery variants. The aorta can be directly anterior to the pulmonary artery. It can be rarely to the left of the coronary artery, and that is often associated with hypoplasia of the right ventricle. And as Professor Anderson alluded to, the aorta can be posterior to the pulmonary artery, and this is exquisitely rare. I'm going to briefly go through the coronary variants in transposition. As Professor Anderson said, you can describe them however you choose, but the echocardiographer and the surgeon should be on the same page of how they're described. We describe them as left-facing and right-facing, but you can also do sinus 1 and sinus 2, as Professor Anderson talked about. And so approximately 2/3 of patients have the usual coronary anatomy, where the left coronary is arising from the left-facing and the right from the right-facing. But the most common anomaly is circumflex from the right, where you can see the coronary artery crossing, the circumflex crossing posterior to the pulmonary artery. You can have variations of single right and single left coronary arteries, and the very unusual inverted coronary arteries, where the coronaries are arising from the opposite facing sinus. So the right coronary artery comes from the left facing sinus, and the left coronary artery comes from the right-facing sinus. And this causes the so-called double looping, where you see a coronary crossing anterior to the aorta and posterior to the pulmonary artery. In some very rare cases, fortunately, you can have the coronary crossing between the great arteries, and that is called an intramural course. It can course in the wall of the aorta, and this can be very problematic for the arterial switch. And so why do these coronary artery anatomy issues matter? Because failed coronary transfer is the primary cause of poor outcome after the arterial switch. And it is highly associated with coronary artery anatomy, as had been shown by Sarah Pasquale's paper many years ago, with intramural coronary having 6.5 times the risk for mortality compared to other variants. And there have been a lot of data to suggest that there can be long-term issues from original coronary artery anatomy as well. We assess the coronaries by the high parasternal view using angulation. Here's the right coming from the right-facing sinus, the left from the left-facing sinus. So this is the usual coronary anatomy. Some helpful hints for the echocardiographers on this call about how to assure you can tell coronary artery issues. If a coronary artery is crossing posterior to the pulmonary artery, and this is seen well in subxiphoid and apical views, it's either the circumflex from the right, a single right coronary artery, or an inverted left coronary artery. If a coronary artery is crossing anterior to the aorta, which is also seen well from subxiphoid and high parasternal views, it's either a single left coronary artery or an inverted right coronary artery. And of course, if you see it crossing between the great arteries, best seen in the high parasternal view, then it has an intramural course. Here you see a single left coronary artery. You can see the right coronary artery is crossing anterior to the aorta here, and you see the LAD and the circ also arising. And then here you see some examples of circumflex coming posterior to the pulmonary artery and passing just behind the pulmonary artery in the apical four-chamber view. This is a beautiful specimen from Diane Spicer showing an intramural course of the left coronary artery making its way through and coursing through the wall of the aorta. You can actually see the intramural segment here. And here are examples of intramural course. Here you see the coronary artery coursing between the aorta and the pulmonary artery, and you can see the flow here between the two great arteries as well. The arch and the ductus arteriosus are best seen in the suprasternal sagittal view, again, because of that parallel course of the great arteries. They sort of sit on top of each other, and this can make it quite challenging for us to be able to diagnose coarctation of the aorta when the PDA is quite large. And sometimes we have to let the ductus close to assure that we do not have coarctation. And finally, Left juxtaposition of the atrial appendages can be seen in association with transposition of the great arteries. And here you see the atrial appendage crossing over to the left side. And as Lee Benson alluded to, this is important, particularly if you're trying to determine the atrial communication and be able to do an atrial septostomy. In this setting, the atrial septum appears perpendicular to the diaphragm. And you also will see absence of the secondary septum here as the appendage crosses its way over. And you'll see bidirectional color flow in that setting. And here you see the juxtaposed atrial appendage. So in conclusion, echo can make the entire pre-surgical diagnosis. Anatomy will dictate surgical strategy, and you need to look for all the variations you can see in anatomy. Transposition with intact ventricular septum requires an adequate atrial shunt, as you've heard. 40 to 50% of patients will have a VSD, which can be any subtype, and outflow obstruction is with malalignment. And coronary artery anomalies are quite common. Look in front, between, and behind the great arteries to give you clues to those diagnoses. Thank you very much.
Thank you very much, Meryl. It's been a terrific session leading up to the surgical management of this disease. A very active Q&A box. We've had an active chat box. I'm getting texts. There's all sorts of things that are happening, which are really fun with this technology. Grace, do we have audience poll ready to go? We take a little break between now and the surgery, or should we wait a little bit, Grace?
We are ready to do the poll to the audience.
Yes.
Sasha, can you release the poll?
Yes.
So we ask you to answer, so everybody can answer very quickly the questions that we are going to make, and then we are going to discuss.
So the first one is very on demographics, and Gil loves this poll. Huh?
How come she who must be obeyed is not on here?
At the moment, Lowell can be happy for us because at the moment we have more than 50% of answer. And I will show you the main results is very interesting. You must be happy.
They're not showing, Sasha. You're going to put them up?
Yes,
shortly?
yes. Coming
Okay.
now.
Terrific.
And another question that we like to share is about where you live, where the people that are connected with us. This is the area of Dr. Van Leeuwen. Here he is.
Wow.
Wow.
Thank you very much, everybody. We are so happy to have people from Latin America very present again. We are very, very happy for that. Thank
So
you.
we have a poll from Bob. A question from Bob. Bob, you want to present your...
I think that this time, hopefully I've made the question correct. Only one of these statements is incorrect. So we all should now be telling me, you should all be slotting which of these is incorrect. Is it incorrect to say that the essence is discordant ventricular arterial connections? Is it incorrect to say that those discordant connections are found most frequently when the atrioventricular connections are concordant? Is it incorrect to say the discordantly connected aorta is always located anteriorly and to the right? Is it incorrect to say the coronary arteries arise from those sinuses of the aorta adjacent to the pulmonary trunk? Or is it incorrect to say the most frequent associated lesion is a ventricular septal defect? So only one of these is incorrect. And this time, hopefully, everybody is ticking the right box.
Wow, it's great to hear your real voice instead of what you sounded like before on an old radio. It's about knowing.
At least doing it the other way, we knew I wasn't going to go very far over time.
Here we go. We have 50% of people. Bob, this is.
We're doing much better. And indeed, the correct answer is that the discordantly connected aorta is not always located anteriorly to the right. And Meryl reinforced that so beautifully in her presentation. And I must say, Meryl's presentation was a wonderful parallel to what I had said in describing the morphology.
And for a rare moment, Professor Anderson, we are in entire agreement.
Indeed, it's good to see we are moving forward.
Now we have a question from Mike Seed, Paul from Mike Seed. Now he's coming. Mike is there or he left?
I'm here.
Say, if you want, you can read your.
I'll let people read it.
It's a shame that F and G are on the same line, but if you want to check F and G, you can just click that one.
When we reach at least 30%, Mike, we will see the. People is going very fast.
I probably gave too many selections.
I do much better with yes, no questions.
Yes. Here we go. Are you happy?
Excellent, yes.
To clarify, Mike, that's older age at surgery, right?
Yeah, older age at surgery and the presence of a ventricular septal defect would be correct.
Gil, you want to send your question?
I sent 3 to Grace. Are they ready to go or not?
Yes, here we go.
Okay, so after a successful septostomy, and I'll define successful as you can see a large hole on the echo and a flapping septum primum. At my institution, there's not a right answer here. I'm just curious what people do. At my institution, we stop the prostaglandin and monitor for hypoxemia, keep the prostaglandin until surgery or other.
I can say is 80%, they look at this.
So 4 out of 5 doctors recommend stopping prostaglandin. Okay, what do you do I'm going to pull the rest of the panelists. Dr. Jatene, what's done at your institution with prostaglandin?
We usually keep the prostaglandin until surgery. We don't usually stop the prostaglandin.
Okay.
As you mentioned in your presentation, which is very, very well presented, but we always keep the prostaglandin until the surgery and stop in the OR or just briefly when the child is coming to the OR.
Understood. And Emery, how about in Marie Langlong?
We, after 35 years, we didn't decide it yet.
Sounds very American of you. Dr. Fraser, I see you're on the line. Welcome, Chuck. What's going? I don't know if you're on. Oh, hey, good morning. It's done at Dell Children's with prostaglandin.
Well, your experience is exactly what ours is. We like to get people off, but during the night when patients desaturate, they'll get put back on it.
Night.
So you just can't win.
I responded to one of our panelists about the same. It always seems at night. It's a good segue. It's a good segue into the next question. What did we get for the results? Do we put the next one up there? Okay, so this will be interesting. So if prostaglandin's been stopped, usually by me, after the septostomy, and now it's nighttime, always, what would I do with prostaglandin? Where would my threshold be to restart prostaglandin? Below 60, below 70, below 80, or something else?
Very fast answer. I will finish because people want to answer.
We may not be right, but we're sure.
Here we go.
So the plurality, but not the majority, close to it below 7. It's always hard to know whether a dip below 70 or sustained below 70. And then the last question I want to ask, which will be a great segue into Dr. Jatene's talk, is about age at surgery. In an otherwise, you put that one up, Grace, in an otherwise uncomplicated baby without low birth weight, without pulmonary hypertension, without all that stuff, when do we usually recommend an arterial switch operation?
This I mutuate from Emre. Emre, this come from you.
So we had 2 separate questions. I'm curious to see what the differences are. So when do you perform switch in simple TGA? Emre, is it okay if I read your question? Okay. Day 0, avoiding balloon septostomy. As early as possible after birth, septostomy is not. Between day 4, septostomy or not, between day 4 and 7 after birth and after the first week of life. And we'll make the same assumptions, Emery. No other complications, prematurity, all that sort of stuff. A straightforward baby with transposition.
Okay, I'm interested, but the tendency is for between 4 and 7 days.
Okay, Grace, do you still have the question the way I asked it? I'm curious to see if people answer the question differently. Because this there's data coming out from that. Grace, do you have it or no? Because we can just go right on if we don't.
No, we don't.
Okay, perfect. So with that in mind, who's up from our group, Sasha? Who's going to introduce?
Now is Grace.
Grace.
Yeah, it's a big honor for me. So we are going to continue to the second part. We are going to talk about surgery. Is there international consensus on surgical technique in 2020? And the first speaker is the president of the World Society of Pediatric and Congenital Heart Surgery and the director of Pediatric Cardiac Surgeon at Heart Institute in São Paulo, Brazil, where I had the honor to be trained. It was a privilege for me to be trained there. And he is going to talk about the arterial switch operation, a 45 years journey. Welcome and thank you very much, Marcelo. Muito obrigada.
Thank you, Grace. Obrigado. Thank you, Sasha and Gil. It's a quite pleasure and very emotional day for me. Today is my father's birthday, so we will be celebrating in many aspects. I have, let me try to fix it. I have no disclosures, and before talking about a 45 years journey after the surgery, the description of the surgery, I think we might mention some previous 178 years before, another journey that began when Professor Anderson showed us was Dr. Bailey's description of the defect. And the term transposition of the great arteries was first used by Farr in 1814. And after that, the first palliative operation with success in improving results was performed by Dr. Blaylock and Dr. Hanlon in 1984, making a surgical atrial septectomy. And after that, many other attempts were done, like Leeuwen and Varkon in 1953, the partial venous switch, which is the initial operations before the atrial switches. And one that had another importance was by Thomas Bakes in 1955, with no cardiopulmonary bypass, made a connection of the inferior vena cava to the left atrium and the right veins, pulmonary veins to the right atrium. And after this period, many arterial operations attempts were done. But finally, the most successful operations began with Dr. Senning's description and Dr. Muster's description of the atrial switches that made a big success and was the choice for treating transposition for many years. As mentioned before, Dr. Harshkin and Miller in 1966 made a very important contribution with the atrial septostomy, the balloon septostomy. And just mentioning some of the arterial operations that were tried before 1975, we can mention Dr. Bailey in 54 and Mustard in 54 that tried to make arterial approaches, but with no coronary approaches. Mustard in 54 had a left coronary transfer with the aorta, but just the left coronary. K and Cross in 1955 and Sani in 59 made two other attempts of arterial approaches, but with no coronary approaches. The coronary were left in the same site. And the first description of both coronary transfers was done in 1961 by Idris when he tried the coronary transfer with an aortic ring. It was not successful, but keeping the concept that you can only switch the vessels, the great vessels, but we might transfer the coronary arteries. And another attempt was done by Balderman in 74 with the coronary transfer with the distal aorta with no success yet. And what's the rationale for insisting in an arterial operation? Despite the acceptable results with the atrial switches, there were worse results in VSD cases. And there was a continuous search of a definitive anatomical correction. Of course, we might have some anatomical requirements for total arterial correction, like the great vessels translocation, the left ventricle must be prepared, but the biggest problem remained over the coronary artery transfer from the aorta to the pulmonary artery. Beginning our 45 years journey, in 1975, Dr. Adib Jatene described the arterial switch operation in babies with VSDs and not in the neonatal period. And after him, his successful description, many fantastic surgeons made a lot of different contributions, like Professor Yacoub in 76 with this two-stage repair with the pulmonary artery bending to prepare the left ventricle. Professor Yves Leconte in 81 described the maneuver that is still being used today, transferring the pulmonary arteries anterior to the aorta. And Dr. Castaneda and other authors described the use of the concept of the arterial switch, the Jatene operation, for the neonate. And in 89, Dr. Jonas described the rapid two-stage repair with the PA bending and the Blalock-Taussig shunt. But as Abraham Lincoln has said, give me 6 hours to chop down a tree and I'll spend the first 4 hours sharpening the axe. So I think that's the same position that Dr. Jatene had in that situation. Despite being a natural researcher and an outstanding surgeon, and not knowing all the concepts that we know now about physiopathology, indications, and surgical concepts, he tried to do the best planning that he could. Where we are in the 70s, the pediatric cardiac surgery knowledge in 75 in Brazil, we had very competent and experienced surgeons, large experience with adult surgeries, but very few experience with small children and neonates. The procedures were considered high-risk procedures. We have poor ICU and hospital structure. And we can only understand better the normal and the pathological physiology with heart specimens. That's what he did. These are some of the specimens that he used to understand the anatomical relations in the normal heart. And these are some experiments he did with resin models, trying to understand the relations of the rings, the pulmonary and the aortic rings, trying to understand the great vessels relations being anteroposterior or side by side, and mainly trying to understand what's the best way to transfer the coronary arteries. Here is the right coronary artery must be transferred to this position and the left. And help in this situation, there was a large experience with general cardiac surgery. his team, his group is being performed a lot of coronary artery bypass grafts, more than 2,000 cases, and the saphenous vein graft implantations in different sites of the aortas, as we can see here. And there was a lot of research about coronary circulation. And then finally, in 75, he performed the first anatomic correction, successful anatomic correction of the transposition of the great vessels. And this is a historical picture of the first child to survive. The child was sent in the cath lab, and this is the right ventricle connected to the pulmonary artery and the left ventricle connected to the aorta. Considering the surgical concepts that we had that he had in that moment, the initial operations, the great arteries were excised, were cut in different levels. This brought some problems like the need of grafts of conduits to repair the pulmonary artery. And the coronary artery translocation was performed by a small button surrounding the ostium. And the reconstruction of the great arteries were performed with the anastomosis in different levels, but left side by side, not with the Lecomte maneuver that was not described at that moment yet. I want to share this interesting video with you. This was during a celebration of the 30 years of the Jatene operation in São Paulo. During a meeting, there was the first survivors were there to pay a tribute for him. And then he had the opportunity to describe how was the presentation in the Henry Ford Symposium. And after the presentation, he sent a lot of manuscripts to different surgeons in the world and received a lot of letters back, like this one from Dr. Senning that said that you succeed in doing what a lot of us try to do experimentally and clinically for the last 20 years. From Dr. Mustard that said, although you have to be a damn good surgeon. From Dr. DeBakey that said that this certainly is the most ingenious procedure. From Dr. Cooley that said this operation may become the one of choice for transposition of the great arteries. And from Dr. Ross that said that he has provided a stimulus to thousands of us around the world. And finally, Dr. Castaneda's letter that said, among a lot of things, that you have made an epoch-making contribution and electrified the surgical world. And after he finished his presentation, Dr. John Kirping, who was coordinating the session, said that, but there must be some problems. Will the anastomosis grow appropriately? Can it be reproducibly? Will the result 2, 3, 4, 10 years after the surgery is as good as the baffle or the atrial switch operations? I think we now have most of these answers. This was the initial results, a very high mortality in the initial cases. And this is a recent experience for our group in the heart hospital with very acceptable results. And here is with an overall mortality of 5.5%, with the 2.3% in type A coronaries. And when we have other coronary anomalies, we have a higher mortality. And I think the whole world, like this data from the Pediatric Cardiac Care Consortium, has shown that since the beginning of the use of the operation in neonates, the mortality, the 30-day and the hospital mortality was very high in the beginning. And then time after time, year after year, the mortality was coming to a level that is reproduced by most of the centers in the world. And the most frequent complication described was the supravalvular pulmonary stenosis, around 10% of the cases, the aortic stenosis in 5%, the aortic root dilatation, it's nearly universal, and the regurgitation in most of the cases, but moderate or severe in less than 10% of the cases. Coronary occlusion in a low number of cases, few number of cases, sudden death also, and aortic dissection and rupture is still unknown. But we might use the information we have during this 45 years to prevent the late complications, like an adequate indication, considering timing and everything that was discussed, like Criteria's operation with extensive dissection of the great vessels, the care with the new aorta length to avoid compression of the pulmonary arteries, the coronary translocation if it's open or closed, technique, then the neopulmonary aortic artery reconstruction, and of course, a frequent clinical follow-up. Just to show a brief video showing that we consider it's very, very important to release completely the pulmonary arteries, as we can see here, the left pulmonary artery and then the right one. And another point that we consider important is to make first, this is our personal preference, to reconstruct the new aorta and then to find the best position to place the coronary buttons, trying to avoid the commissures and to put in a position avoiding kinkings and leakings. And the supravalvular pulmonary stenosis could be also present by the compression by the new aorta. When the new aorta becomes longer with a long length, it could compress and stretch both pulmonary arteries caught in this kind of situation. And the use of the patches that were used in the past to reconstruct the new PA were preferably used by bovine pericardium. And what we observed during the years is that there was a retraction of the patch. And we can see here in one of the cases where the patch retracts completely in the valsalva, in the valsalva sinus. And when we resect the patches, we can have a better valve and reconstruct. other tissue, like we are using now a single patch with fresh autologous pericardium. I think all these technical aspects will be shown in the next presentations. Another point is about the aortic regurgitation. This is a experience for Dr. Lang's group that showed that most of the cases there was an increase in the grade of the aortic insufficiency coming more than 20 years to the grade 1 and between 1 and 2. And but there are freedom for aortic insufficient. Most of the cases was intact septum, and after that was the VSD and the Tausig mean and double outlet right ventricle was more a grade 3 and 4 aortic regurgitation. Another aspect, as everybody knows, that the right-sided pathology are the most responsible for the first 3 operations. This is a study from the Mayo Clinic by Joe Durrani and his colleagues, but the left-sided pathology must be considered. And there is a lot of cases coming that we need to replace the aortic valve, replace the aortic root, and repair the valve or make a patch annuloplasty, because the cases are coming, the indications could be earlier to avoid the aortic valve deterioration. We had in our group 8 recent cases from 14 to 19 with 5 Bentel de Bono operations and 3 preserved aortic valve with the Tyron David technique. Finally, I'll use some very few minutes of this presentation to pay a tribute to Dr. Jatene. And there is a word in Portuguese that's called saudade. There's no translation to English, but it's something like missing, longing, and yearning. It's a big wish of meeting again, touching again, or just remembering. It's surrounded by good feelings and a great desire of sharing great moments on his personal history. And it's an opportunity to keeping closer, which is exactly what we are doing today. And there is a lot of things about his history, a lot of contributions to the science. Here's the Web of Science, a lot of citations. It's an H index of 40 during all his career, a lot of articles, citing articles, and many aspects. Just a brief history. He was born in a very small city called Chapuri in the state of Acre. Here is Brazil, and here is Bolivia. It's in the border of Bolivia, just in the middle of the Amazon forest. And he came to a city in the southeast called Uberlândia with the age of 10, came by boat, and he took more than 40 days to come from Chapuri to the southeast. And then he decided to study medicine. Here is him as a medical student. He graduated in 1953 and had a strict relation with Professor Zerbini in the 2 last years of his graduation. And after that, he's one of his mentors. He had performed, the teams led by him had performed more than 100,000 cardiac surgeries here in Brazil. And he personally had performed more than 40,000 surgeons as the first surgeon. And he practiced, daily practice till the age of 82, and then he needed to stop because of a terrible back pain that costs some surgeries to fix the problem. He had a lot of experience with experimental laboratory, and he had a lot of personal creations like artificial hearts, artificial heart valves, pacemakers, defibrillators, cardiopulmonary machines, and oxygenators. VADs. He was working in a VAD when he passed away, and research with a lot of anatomical specimens. He was still the dean of the medical school during 4 years, and he always had a vision to have no political part, but he assumed a lot of governmental positions like the health state secretary of the state of São Paulo. Here is his among the population. And he was health minister of the country in 2 different governments, from Fernando Collor and Fernando Henrique Cardoso, when he said that the main problem of the poor people was that they only have poor friends. There's none for them. And this is reality in our country. His main hobby was, he was a farmer, and here's the farm that he had, and here is my mother. And he liked very much to have a lot of activities on the farm, like riding horses, cattle, and agriculture. We are in four brothers. There's two men and 2 women. 3 of us are medical doctors, 2 surgeons, and a pediatric cardiologist, and I have a sister that is an architect. And here is part of the family with the 4 sons, with a part of the grandsons, and here is the family growing with a lot of grandsons and a lot of people. He liked to say a lot of phrases, and he write a lot of things. And but one of his trademarks was that is said that I never discuss the problems. There are people that loses themselves discussing the problems. I just discuss solutions, and we can confirm this. And he's a very religious person, and following the thoughts of Mother Teresa from Calcutta, he said that the opposite of fear is not courage, but faith. And he never complained. I can confirm that, and he always said that the present is wonderful. I had a privilege to introduce him during the meeting of the World Society of Pediatric and Congenital Heart Surgery that was held here in São Paulo in 2014. I introduced him for what was his last scientific presentation. He passed away some few months after this presentation for a public of close to 700 people, and he was applauded for 2 or 3 minutes, I'm not sure, after his presentation. Here is the 3rd generation of the family. 2 of my sons he's a resident in cardiac surgery, and she's a pediatric cardiologist. He's my son-in-law, he's anesthesiologist, my sister. So we are in the 3rd generation of the family. And finally, I just want to thank Marshall Jacobs and Christo Chervenkov that wrote in the World Journal a tribute to the patriarch, saying that I have seen further it's by standing on the shoulder of giants. While the metaphor is much used, it's difficult for any congenital heart surgeon to think of shoulders broader, more robust, or more welcoming than those of Professor Jatene. So thank you very much for the opportunity.
If we were in a big conference room at this moment, there was a standing ovation, because thanks, Marcelo, you give us. It seems like we were in a room. We saw also the chat from the people, and thanks again. We really don't believe what you are giving us. I'm sure it's not possible to feel what your father lived. But now we have to go on, and I ask Davide Calvaruso, that is my associate here in Taormina, that was trained by this guy from Marina Lenon, Professor Emre Belli, that I would like to introduce him. Davide.
Davide, before you start, I just wanted to say a couple of things. Some things have been coming up on the chat. This will be recorded and will be on our YouTube channel. Please follow us on social media. And many of the things that Dr. Jatene just talked about in terms of long-term follow-up will be amplified in great degree in the part 2 of Transposition, which is on July 2nd. Davide.
Okay, thanks, Gil. So hello, everybody, and thanks to Marcelo Jatene, how beautiful history is and how beautiful, how important is our past for our future. Well, I'm proud to introduce to you all Professor Emre Belli, Director of the Department of Pediatric and Congenital Disease at Marie-Lannelongue Hospital in France. I am very happy to present Professor Emre Belli for at least 2 reasons. First of all, because Marie-Lannelongue Group represent a very important piece of history in treatment of TGA. And this group have contributed substantially to the clinical literature about transposition. Remember Professor Claude Planchet. The second reason is that I worked with, I had the pleasure to work with Emre Belli for 2 years, and I learned a lot from him. Not all in surgery, I'm talking about all the Russian films, movies, and music, jazz, electronic, electro jazz, and so on. Actually, Emre was the first for me to demystify arterial switch operation, explaining me how to perform this operation and making it simple. So Emre, thank you very much to be here with us.
Thank you, Davide. Let's go because we must be short in time. Okay, so arterial switch operation is not that rare. We perform in all type of transposition, but also double outlet with subpulmonary VST, and also in very challenging non-committed VST cases where it is more suitable. It's rare but challenging to the pulmonary infundibulum, then make a switch. Mairanong's history is contemporary with Boston in transposition of great arteries after the failure of very talented surgeon. I think simultaneously in both sides of the ocean, neonatal switch has become a procedure, routine procedure for the treatment of the transposition of great arteries, thanks big efforts of both cardiologists, surgeon, and intensivist. Many improvements occurred. Prenatal diagnosis has changed dramatically the aspect of this pathology. Monitoring techniques improved. Mairanong is based on the technique introduced by Claude Planchet, which is maybe a little bit more adapted to different conditions. However, it became standard repository technical for all types of the transposition cases, which with the improvements of the postoperative care, all these improvements resulted in the limiting the exposure of the babies to the deleterious effects that we know. This is a recent study that not yet published, where a certain amount of consecutive simple TGA were analyzed, and you can observe how things has changed in time. Let's say in 2004 and 5, and the unique thing we didn't change is the prostaglandin. The remaining parameters shows how the management has improved, and as well as the outcomes. So what is, Sasha put the title of perfect switch. What is a perfect switch, which I call routine switch? How it must be in Mairanong, at least. All is here. It must be, as the techniques are well defined, and we don't cool, we don't warm. The surgery takes around 2 hours with less than half necessary to perform the repair, with 1 pack of plasma, fresh frozen plasma, and normothermia and intermittent antegrade aerobic cardiac arrest. Despite the 6 minutes that it adds, 5 minutes, it is at a cross clamp time. We don't put anymore the big chest drains, and we use in the almost all patients, at least until the intensive care, maybe some vasopressor can be necessary if the patient has to remain intubated, but enoximon has dramatically improved the stability of the patients. Only morphine in ICU, early extubation, the hours following intensive care stay, and of course, no residual lesion if there are additional lesion too, except some pulmonary trivial regurgitation, which one where we analyzed this 901 patients. The statistical technique is very long to explain. However, many of them are without prenatal diagnosis. What we found out that the best time to perform is around 7 to 8 days. In terms of mortality, of course, in terms of length of ICU stay also, because mortality can be put under the shoulder of coronary ischemia. However, length of ICU stay is mainly related to the management, but also the patient's condition, as the management is stable, is fixed for everybody. No hurry to go fast, and no need to wait too much, as showed our friend from the analysis of brain MR. So nowadays we perform according to the weekends. Around the 5th day, the switch procedure. We wait 1 week when there is a TGA, VST, aortic ductus dependent aortic arch obstruction, and TGA, VST is according to clinical tolerance. However, it can go up to 1 month. But one shall know that if there is a light subpulmonary stenosis with a good pulmonary valve, if you wait more than 5-6 weeks, this stenosis will be emphasized in time. So surgical anatomy is very well showed by both Bob Anderson and Meryl. Coronary malalignment is a severe issue. Preoperative investigations shall emphasize this parameter. Coronary artery classifications, there are many. We have also our own classifications, but it seems that in Europe, people use more Jakob classification, and in US more Leiden classification. However, you have the normal anatomy, loop anatomy, interarterial, intramural coronary anatomy, and the single coronary artery showed shortly here. So two things, pericardium, we use it fresh, but it doesn't change too much if you want to fix it. At least in follow-up, it doesn't change anything. And I personally use a TAN pericardium when I do TGA multiple VST, where there will be VST and banding at the switch and banding at the end of the procedure. And we keep the pleura closed if we can, because for the mechanical of the lungs, mechanical status of the lungs is much more better, in particular when you do surgery in normothermia. This is an L malposition, which is a rare condition. So Planchet was saying that the heart view is like a map. It shows you it tells you many stories. You have to know how to read it. Like this coronary is, of course, there is no real subaortic RVO2 or this kind, but this coronary goes there because there is some muscle to irrigate. This is for the more for medical regular anterior posterior normal coronary anatomy switch is in OR with a comfortable aorta. So we tend to cut the aorta relatively high. Before complete section, you have to check out inside if there are superiorly positioned coronary arteries, it can happen. So you have to be, and you cannot see always from the outside of the heart. From another patient, but it shows well, you have to, after the aortic section, you have to dissect inter-aortic pulmonary space deep as possible until the myocardium. Of course, if you know that the patient has an infundibular VSD, you have to not to go that far because you will be entering in it. However, you have to see the continuing the procedure. Coronary harvesting, you have to privilege the bottom. So you see the ostia. First, I always start from the right side, and I harvest the coronary with scissors with a large cuff, allowing to let's say compensate any small mild imperfection while reimplanting. After the intimal section, you can use the Bowie electrical bistoury, cautery, to mobilize the coronary. We are not big fan of extensive mobilization always. Because when you skeletonize the coronary, when it's not necessary, you have to be sure that you will not make kinking of the coronary. This is the section of the pulmonary trunk, low section just above the tip of the commissures. This is the Lecompte maneuver. Once the pulmonary is, we change the place of the clamp, and we put stitches on the commissures, and this particular patient has major malalignment of commissure. As you see, commissures are laterally, and the anteriorly there is a commissure. Afterwards, there is trapdoor. I always use trapdoor for the left coronary artery, since it is not a loop, anterior looping coronary. Sometimes it can be not necessary, but let's say if you don't know, do the trapdoor for the left one. Afterwards, the 6 o'clock of the cuff should come in the angles of the trapdoor. So you have to stitch. We use 8-0 for the coronaries. You have to stitch, and you have to adjust, gather with the larger bites on the coronary and closer bites in the aorta in order to create a sort of avoiding stretching in the wrong sense and permitting to enter all the adjusting the sutures. The left coronary shall be below the level of the ostia, shall be below the level of the tip of the commissures. For the right one, the ostia should be above. So you make a small incision. Some colleagues didn't do any incision. I do a small incision and fix this that way. This congruence is corrected by adjusting the suture line main in the left side, but we can do a small counter incision for the left, and more important, because he is higher positioned, counter incision for the right coronary, adjusting the suture line and also avoiding any stricture. The risk is small. This is from last century because we're using crystalloid cardioplegia, but at 30-minute cardioplegia, already you can see that the coronaries looks satisfying. You're already happy and you can think to what you will eat in the lunch. Pericardial patch shall be generously harvested and inserted by suture line and respecting commissure if there is no detachment of the commissure. Once the pericardial patch is proximally inserted, we de-air the left cavities and we complete the procedure by the establishment of the continuity of the RVO2 by pulmonary anastomosis. So this is the regular cases. However, challenging and influences outcomes because we still are still losing patients for coronary ischemia. It's rare, but it happens. This is a type C, let's say both coronary from right sinus. The strategy is always the same. We harvest a common cuff. A common cuff, we detach the, you see the left and right ossia, you have the intramural course of the coronary. We detach the commissure first and then harvest both coronary artery with a common cuff from one commissure to the other, because this shall be the intramural, you don't know how far to the anterior commissure of the pulmonary artery. It's a very meticulous time because this defines how much tissue you will have to stitch, and if you miss tissue, you can be in trouble despite proper implantation positioning of the coronary. Once the coronary cuff harvested, we check the intramural course and we unroof. The unroofing shall go as far as possible. Of course, it's not the same size and condition of the InCor patient, but you can still add a stitch one if you go outside of the intimal continuity. The common cuff into balanced cuff, leaving enough tissue in both sides. This is our standard approach. I always be able to do this in type C patients, despite some cases appear to be single coronary. In this case, the left coronary is more extensively mobilized because it comes from the right sinus, so the positioning shall be different. This procedure was performed in the 80s. Claude Planchet used Gore-Tex patch harvested from a conduit in order to keep the convexity with close to 500 switch cases. One word for the VST, we always close in the majority of the case VST from the PA. At early experience, right ventriculotomy was performed, but in 90s, we observed that when we closed the upper edge of the VST through PA from the Valsalva sinus, this anterior cusp of the pulmonary artery was suffering, and aortic insufficiency was not uncommon. So we modified the technique, and the roof and the upper edge of the ventricular septal defect stitches we are passing from right ventricle to the left through interventricular septum, or sometimes from outside to inside from the right you have a double loop, you don't stretch the coronary, you can put easily from here inside the pledgeted stitch to fix the coronary. Aortic arch obstruction, coarctation or interrupted arch, at early experience we used direct anastomosis, then switch, but this congruence shall be corrected. We are using a homograph patch or pericardial patch, not as hypoplastic, not as generous as hypoplastic left heart because you have the Leconte maneuver, but this is also a standardized technique. So to make a sort of list of tricks, so AST we always close. The supposed benefit of residual shunt is demonstrated. So if there is a problem, you add another unknown parameter to the coefficient. So all shunts are closed. Pericardial patch must be large, enough large. Aorta is section high and PA low because many reasons coronary will go up and the pulmonary artery will not be stretched by a huge aorta behind. Mainly these two reasons. Don't hesitate to detach pulmonary valve commissure if your cuff will not be enough large. So left coronary is slightly below the commissure, right ostia slightly above the commissure. The discongruence adjustment is not from the you start at 6 o'clock for both ascending aorta and the pulmonary artery. Don't gather, don't adjust because right coronary artery don't have to go back. However, on the left side hand, right side hand, I mean left side of the suture line, you can adjust as far as you want. A counter incision helps to correct the discongruence, and if it's a older patient with Tausig-Bing anomaly and huge no coarctation, you don't have to enlarge the aortic arch and huge pulmonary artery, you can make a triangle resection from the posterior sinus and stitch it. It doesn't destabilize the neo-aortic valve. If the distal pulmonary pathway is restrictive, be very careful. You can use locked suture. Coronary loops in presence. If you have an anterior loop, you have to insert the pericardial patch before the insertion reimplantation of the coronary. It's much more easier. When you decannulate with anterior loop, don't pull back the PA because you will stretch the infundibulum and you will make ischemia, and more you stretch, more you have edema, attention, in particular in Tausig-Bing with double loop. Type C, we explain during the video. Left coronary shall come above the suture line. It has to be avoided to king because you have a segment at the end of the intramural course where you have a normal coronary adventitia and neonatal coronary adventitia. This area must be straightforward, not kinked. If you have a side-by-side relationship, great arteries, don't hesitate to displace the distal anastomosis of the pulmonary artery to the right side, avoiding stretching of the left PA, in particular if you have a aortic arch obstruction patch. Because of that reason, the proximal patch size must be not huge in this condition. And if you have a TGA VST coarctation, always have a look below the native aortic valve on the RVO2. You will there will be a parietal muscular band to divide, which will solve many problems. This three condition is to be debated to another presentation, which is the bicuspid pulmonary valve and LVO2, where our study showed that when the risk starts, when the z-score is below minus 1.8, multiple VSTs in presence, we prefer not primary PA banding, but we do switch and banding, eventually closing the principal VST and expecting spontaneous closure or surgery in a larger patient. Late referral is rare. However, we use rapid two-stage below a certain age, and also if the myocardial mass and mass volume index is not satisfactory. And to finish my tribute to Claude Planchet, Jacqueline, our and Alain Seraf, who are the principal contributors to this program. Thank you for your attention.
Thank you very much, Emre. As you say, as we say, that we are very lucky in Europe because the School of Paris was an amazing school for all the European surgeons at least. But now we discussed with Gil Wernovsky that I was so happy because today we have the opportunity to have the three perspectives. We have the Brazilian, South American perspective, we have the European perspective, and now it's time to have the USA perspective. So I thank you very much and sorry for the delay in time to Professor Fraser, who is director at Dell Children's Hospital in Austin. And of course, he will talk about very long personal experience with the transposition of the great arteries.
What's happening? I don't know. You should be in the meeting. Go to the Zoom icon there.
You have to share, but you are sharing in.
Sorry. Back down there, and then go to the meeting controls. Yeah, it's a problem.
No,
So
no.
first again,
you don't need to launch again. Close the Zoom link. You can close this.
The control panel over on your laptop. Close.
Wait. Wait a moment. If you give me remote control, if you are...
Yeah.
Give me remote control.
While Sasha's doing that, Dr. Belli, there's a question for you in French in the chat panel.
Let's go. I'm here.
If you could type it into the box, that would be great. But perhaps everybody else could see it. Thank you.
Bonsoir, docteur.
While we're also waiting again, I want to remind everybody on July the 2nd at the same time we'll be having the long-term follow-up of the Arterial session.
Where it says stop share.
So I answer orally. You know, perimembranous VST is invented in Europe. We more likely use a conotruncal literature. However, whatever the VST is, since is not from the easily, if the PA is a hypoplastic or bicuspid valve, which you have concern to reach the VST, you can close through the right atrium. It will take more time and destabilize the tricuspid valve and all this thing. But there is no, it's not a rule. I told what I said, what we are doing. I think it's totally honest to close through the right atrium, and if you're in difficulty even to do right ventriculotomy, expecting some consequences.
Okay, thanks, Emery. We'll go over to Dr. Frazier. Thanks, Chuck, for spending the time to fix that.
Well, I'm not sure it's fixed. Do you have me?
See your
Okay. Okay,
yeah.
great. All right. Well, we'll see if we can make it work. It's great fun to be a part of this conference. I've not done one of these, and this such a broad audience. So the forum is spectacular, and the previous speakers are humbling. So I will just share the Texan perspective on this amazing journey of transposition. And my only disclosure is that this is my favorite operation by a long shot. This is our experience now, 25 years through today, 404 total patients with infant arterial switches, and we published our Texas Children's results earlier this year involving our 23-year experience, and it was very gratifying. We had a lot of years of practice, and it seems like we did between 10 and 20 switches a year over the course of time. The constellation of anatomy was much as was described by previous speakers. About half the patients transposition intact septum, and then you see the breakdown there, including 36 Taussig Bing patients. Male preponderant lesion, as people know, and it's been very gratifying to see the overall hospital survival. And we started looking at this, realizing that we hadn't had a mortality in this millennium. So we thought it might be good to write it up. We did have one out of hospital death in a transposition intact septum, which was probably an arrhythmic event. But other than that, the patients have done very, very well. And again, really personally satisfying to hear someone as accomplished as Dr. Belli share some of the tricks that he has learned over the course of an amazing experience that we think also are critically important in reducing that overall acute mortality risk to essentially nil. Unfortunately, there still are patients that present for reintervention, as has been published previously by other authors and was alluded to in one of the other presentations. The right ventricular outflow tract can be problematic, particularly in the Taussig Bing anomaly, and the pulmonary artery reconstruction still can be a problem. So the message that we, and I think many agree with, is these are lifelong patients. They have to be followed for life, and will require most probably some sort of a reintervention over the course of an expected long lifespan, but we'll see about that. But again, the survivorship has gotten better and better and better. And this compares very favorably to our overall surgical experience at Texas Children's before I left there in 2018, a little less than 3%. Much has been said about the coronary anatomy. Meryl Cohen did a marvelous job of presenting the echo nuances that I completely agree with. It's still amazing to me that centers, some centers continue to advocate for doing preoperative cardiac catheterization or CT angiography. I personally do not think that is at all necessary. I do think that the surgeon of this era has to be prepared to deal with all coronary branching patterns. And as Dr. Belli suggested, there is a way to take care of all of them, and thereby trying to be completely precise on the coronary anatomy before surgery, in my estimation, is not necessary. Dr. Benson talked about this Raskin procedure. I very much agree that it has an important role in the management of these patients, and I favor a septostomy just to allow the patients to get off prostaglandin if that's possible. Again, as Gil has alluded to, sometimes that's beyond our control, but I do think as a surgeon that it's nice to have the patients off of prostaglandin. No one's ever really proven this, but my personal opinion is if the babies can get off of prostaglandin and feed before surgery, their postoperative course is faster. I think they get out of the hospital faster, so maybe somebody wants to study that. But anyway, so I'll just run through our approach to the arterial switch operation from the surgeon's viewpoint. We almost uniformly use bicable cannulation and mild hypothermia. If we're going to do an arch reconstruction, we'll sew a graft on the innominate artery and use a period of antegrade cerebral perfusion. We have not used circulatory arrest in any of those 404 patients. We would harvest a pericardial patch before going on bypass. I agree that it's useful to tan the pericardium and glutaraldehyde if you're going to close a VSD, but otherwise I just keep it fresh. Transect the aorta very high, as was alluded to previously, and the surgeon must identify the coronary origins before committing to the aortic transection, because the strategic location of the aortotomy will have relevance to how optimized the button harvesting is. Now, one point that I think was, again, alluded to by other speakers is just looking at the relationship of the coronaries and the great vessels. And what I tell my trainees is we look carefully at the orientation of the great vessel before getting started, because it will tell you the story of where the coronaries want to go. And I like to mark, where possible, the position that it looks optimal for me for the coronary translocation, and then as was previously noted, widely mobilized the brain and pulmonary arteries. Liberal buttons of the coronary ostia is really paramount. As was discussed earlier, in the more challenging posterior related so-called shotgun ostia, you almost always can separate the two ostia if you're very, very careful about that. And we completely agree that the trapdoor flap geometry offers a lot of forgiveness in the arterial switch operation. So the section of the pulmonary artery, again, as is shown here in the diagram, I often will mark that before we've gone on bypass, where I think those coronary buttons are going to optimally sit, and then proceed with the coronary translocation. I usually do create a trapdoor flap incision for both coronary arteries, but it's not always necessary for the right coronary artery, as was said earlier. And then we typically proceed with the neo-pulmonary sinus reconstruction with the heart beating, and use separate patches for that. Again, the key to the operation is to minimize the actual axial rotation of the coronary, translocated coronary arteries. And it's very correct that the more you mobilize the coronary arteries, the more risk of misadventure. And the trapdoor flap incision offers a measure of forgiveness in that coronary translocation. And that's the final result. Again, just a few more technical points. We continue to use crystalloid cardioplegia. We haven't changed. It works well for us. We give it every 20 minutes. Liberally mobilizing the buttons. There's no reason to be in a big hurry in these operations. And again, just take the coronary button right down off of the hinge point of the aortic valve, the pulmonary artery transection, assess the commissure alignment. For those more difficult coronary patterns, it may be useful for the surgeon to go ahead and put the aorta back together. We do that particularly in the Taussig being heart. I find sometimes it's easier to define the optimal location of the coronary translocation with the aorta put back together. But in the more straightforward cases, we'll just go ahead and transfer the coronary arteries before reestablishing aortic continuity. We also use atoproline for the anastomoses and really very accurate minimal bites with a little bit of a dog ear on the anterior ostium. I believe that this functionally increases the length of the ostium and again allows a little bit more forgiveness in the translocation. And then after reestablishing aortic continuity, we resuscitate the heart and finish the operation, including the neopulmonary reconstruction with the heart beating. We have favored an all autologous arch reconstruction technique. If it's a patient that's requiring an arch reconstruction, we'll do that before proceeding with the switch, and almost never have to use any sort of heterologous material in the arch reconstruction. Now, much has been said about the left ventricular outflow tract. I'll just briefly mention that in many of the cases, there is the opportunity to avoid an Aikido operation in our experience. And one is just like this patient, where if you looked at the preoperative echo, it would be very easy to be taken down the pathway that this left ventricular outflow tract may be inadequate, and that the pulmonary valve annulus may be inadequate. But we think that those all deserve exploration, and as was done in this patient, the left ventricular outflow tract resection can be accomplished both through the pulmonary and aortic valves. Then the integrity of the outflow tract assessed, and then the arterial switch proceeding as usual. Another subject that often is problematic is how small is too small in these children, and Gil spoke about this very nicely in his presentation. Trying to temporize in these children, particularly if they're prostaglandin dependent, can be enormously difficult. And our opinion has been that pretty much irrespective of size, we'll proceed with the arterial switch operation. We have quite a number of patients that we've done the switch on less than 1,800 grams, and this is my personal smallest patient, 760 grams, and she was frankly in florid heart failure, profoundly desaturated despite a large atrial septal defect, and we proceeded with the operation really per standard, other than we developed a microcircuit for her cardiopulmonary bypass care. But the point of this is that other than the miniaturized cardiopulmonary bypass circuit, even in a 760 gram patient, everything that you need to do is right up in front of you. So we're not talking about structures that a cardiac surgeon's not accustomed to dealing with. And relative to the size of the patient, the coronary arteries are eminently switchable. So to have a baby like this struggling in the intensive care unit, perhaps getting necrotizing intercolitis or other complications, it's better just to get on and do the operation. And this child did very well after the surgery. Really, the hardest part of the care of the patient was the NICU management, but she did very well with a restored physiology. You know, a question that young surgeons often ask me is that, you know, have you gotten so good at this? And the answer is there were a lot of people before me who worked out the problems. So our generation, really, we're sort of more the accountants. And many people have said a lot about their mentors, appropriately so. And of course, the visionary work of Dr. Jatene in putting this idea to fruition. But I have to give Roger Mee credit. My mentor, Roger Mee, when I was exposed to the arterial switch in early 1991 in Melbourne, at a time where Roger had really shown that this could be done very accurately and very safely, really set the bar for our career, for my career. Our current intraoperative management, we use high flow bypass, mild hypothermia, pH stat, CO2 management, high hematocrit, NIRS monitoring. We will use antegrade cerebral perfusion for the arch reconstruction. We put a left atrial line in everyone. I do think that that's important. 95% of the time you can get by without a left atrial line, but the few that are potentially going to struggle, it's very helpful. And that has worked well for us. Placing the left atrial line is very safe. We do not have complications related to it. And we usually take the LA line out in a day or two after surgery. We do place peritoneal dialysis catheters on our patients. It can be an important adjunct to oliguria. We do use continuous near-infrared spectroscopy management. One question that I didn't ask earlier when people were talking about preoperative SAT was how frequently are people using NIRS in managing babies before surgery? We do that standardly, and that does help us decide what to do with the prostaglandin in some patients. And then finally, what's next? I came down after an operation a couple of years ago and said, well, we know so much and we know so little about these patients. And I know that's the subject of the next conference, but basically I mapped out what is the life like of a fetus diagnosed with transposition through the course of an entire normal lifespan. And so what we've done here in Austin is to develop a lifetime journey map for our patients. Much is based on the tremendous work of others that have gone before us, but much is also based on inference, and that is what happens later in the lives of these patients. It's incumbent on all of us to think about this in the entirety of the lifespan of these children, and I'm sure we have a whole lot more to learn. So again, greetings from Austin, Texas, where we're having a great time building a new program. And this is our team just this week doing a Norwood operation. And we're just honored to be a part of this fantastic conference and symposium. Thank you.
Thank you, Chuck. That was just fantastic. I love the roadmap concept, as you know, and I have to find a way of getting a copy of that picture of you and Roger. That was just really fantastic.
No problem.
I know we're running long, and I really appreciate the fact there's still over 900 people that are still logged on after 3 hours of this, and you're not going to be disappointed. I'm really pleased to introduce a long-term friend, fellow Philadelphia Eagles fan. I've known Dr. Josh Salvin for a number of years, from the time he started his training till now, where he is a staff intensivist at the Cardiac Intensive Care Unit Children's Hospital in Boston. And he will, obviously we all know that all the arterial switch operations presented by our surgeons today come out perfectly, and postoperative care is particularly easy. But Josh is going to talk about some of the bumps that might happen after a successful arterial switch operation. Josh. I think you're muted, Josh.
I was muted. Sorry about that. Thought I would have this down by now. I just want to thank you, Gil and Sasha and Grace, for the incredible opportunity to present today. This has just been an amazing group of faculty on this panel, and it is truly humbling to be part of this group today. I'm going to talk a bit about the postoperative care following an arterial switch operation. I don't have any disclosures. As we've said, and many of the speakers have said, up until this point, over the past 30 years, 30 plus years, there's been a steady improvement in morbidity and mortality. And this is related to many of the factors that previous speakers have spoken about so far this morning. Prenatal diagnosis and postnatal imaging has been essential, where you have patients that present in a relatively well state to our cardiac ICU after an uneventful delivery and perinatal period. We're able to get very good postnatal imaging by non-invasive measures, as Meryl described earlier this morning. Preoperative stabilization is much easier when you know what's coming in the door, and as an intensivist, if you know that there's a prenatal diagnosis of a patient who is going to need an atrial septectomy, for example, because they're prenatally diagnosed with an intact atrial septum. We have cath lab, anesthesia, all the resources right there. When the baby's born, it can come to the ICU or cath lab as appropriate. And that's made our outcomes improve steadily over the past 30 years. Surgical technique, which has been talked about by Dr. Belli, Dr. Frazier, and others, has improved as well. Bypass strategies, and of course, the postoperative management. So we'll touch briefly on these in the next few minutes. I'm not going to go through all of this. This is from the STS data from the United States over the past 4 years. Dr. Frazier talked about a lot of these. These are all comers from all centers that are reporting outcomes to the STS database. Overall mortality for a quote straightforward arterial switch operation, meaning intact ventricular septum, is 2.2%, and you can read the other outcomes there. The length of stay has been steadily decreasing, I think, as there are advances in postoperative care and surgical technique. The cardiac arrest rate still remains somewhere around 5% in most centers, slightly lower depending on the center. And the use of postoperative ECMO in the first 30 days is somewhere in the 3 to 12% range. Early reoperation, I'm not going to go through the details of which operations, which interventions need to be intervened upon, but it's again somewhere around 4 to 10%. Arrhythmia in the ICU is still something that we take quite a careful look for. Delayed sternal closure, I was actually interested to see this, is 25 to 50%. It's lower at our institution, but I think there's a lot of variability in centers reporting to the STS database. Renal insufficiency is an uncommon complication. We do, again, as Dr. Frazier's group does, place peritoneal dialysis drains, which may mitigate some of the effects of the renal insufficiency. And as we become more and more aware and conscious of neurologic injury, we are detecting in anywhere between 0.4 and 2.6% of our patients. So this is one of the most important points that I think I can put out there, is that the postoperative care starts at birth. When the baby is born, we must, as an intensivist or neonatologist caring for these patients in the preoperative period, ensure adequate mixing to improve oxygen delivery. And that could be by opening the atrial septum if necessary, by maintaining patency of the ductus arteriosus with the pitfalls that Gil described. But maintaining adequate mixing, improving oxygen delivery is essential for these patients. Monitoring for reverse deferential cyanosis in the preoperative period as an indicator of pulmonary hypertension or evolving left ventricular outflow tract obstruction is essential. I couldn't agree more with Dr. Frazier, although there are not great data to support this, but feeds and nutrition preoperatively, I personally think makes a huge difference in the postoperative outcomes of our patients. And the timing of the arterial switch operation, as we've heard about earlier, is up for debate, but I think critical to the outcomes, the postoperative outcomes of these patients. Dave Wessel said this to me as a fellow when I sent a patient to the operating room on rounds. I think I reported the echo report said, don't, with all respect to our echocardiographer colleagues, look at the images. And as an intensivist and a cardiologist, I think having firsthand knowledge of the size of the tricuspid valve, the arch, the coronary anatomy, the VSD type and location, it's not that we don't trust our surgical colleagues to be able to handle anything that's thrown at them in the operating room. It's just that if I have, as a cardiologist, an exquisitely good idea of what the anatomy is preoperatively, I can already start to put into my head what are the pitfalls and the problems that we might see in the postoperative period, anticipate and stay one step ahead of those potential problems. So primary data, look at the data yourself, look at the imaging data preoperatively. If there's questions, sit and address them with the surgeon preoperatively. After the operation, I'll skip straight through the 4 hours that went from looking at the imaging, coming back to the ICU. Face-to-face communication, again, is a principle that we've really tried to instill, and I know many centers have done, between the ICU anesthesia team and the surgical team. We in Boston Children's do a Formula One handoff, which was developed from, again, the work of many, many other centers out there. The Formula One handoff starts with the surgical team presenting the patient history, then goes to the anesthesiologist who will talk about induction of anesthesia and pre-bypass strategies. The surgeon will then present the operative details, including any mishaps that in the operating room or concerns about residual lesions. Anesthesia will talk about post-bypass course, and then we'll review the post-bypass imaging, whether that's TEE or an echocardiogram, depending on the size of the patient. any residual lesions that were found, direct hemodynamic measurements, which are performed in the operating room, such as saturations in the SVC or the pulmonary artery to assess for residual VSD, if that was part of the anatomic and anatomy of that particular patient. And this is really a time for the attending surgeon to talk to the anesthesiologist, the intensivist, the operating room, and CIC nursing staff, and for everybody to get on the same page right out of the gate. So everybody starts at the starting line with the same information, hearing it directly from the people involved. And we really have shown an improvement in our outcomes. And this is a photo, it's an old photo. This is obviously not a patient that had an arterial switch. That would be a very late arterial switch operation. But of all the folks that are involved in the Formula One process. We do a lot of continuous monitoring at Boston Children's. We use intracardiac lines. Every patient has a right atrial line. Almost every single patient has a left atrial line. Totally agree that 95% of the time left atrial line is not necessary, but when it is, you're really happy that it's there. Those lines tend to come out within the first 1 to 2 days. Every patient has an invasive blood pressure monitoring, pulse oximetry, and tidal CO2, with particular attention to the waveforms on the ventilator and the end tidal waveforms. We do use continuous EEG, ECG and EEG monitoring. We use NIRS in our neonates and continuous temperature monitoring for all patients. And then of course we use intermittent monitoring, the most important of which that Gil and others have taught me is the physical exam. Walk up to your patient, put your finger on the toe of the baby, tell me what the temperature of the baby. You can tell a lot about the cardiac output just by that simple maneuver. And then listen, examine the baby well when they come back from the operating room as a starting point. The physiology can change dramatically over the first several hours, and you need to have a baseline exam. We do intermittent monitoring of gross organ function. We use serum lactates, we use serum creatinine as a gross organ function. Urine output is a very somewhat continuous, somewhat intermittent marker of end organ perfusion. And we tend to use internal jugular lines, and we can measure intermittent venous oxygen. They're not terribly different in this patient population than other patients with the biventricular circulation. That's to optimize cardiac output and oxygen delivery, to ensure adequate gas exchange, control coagulopathy, of course, and to mitigate the best we can the inflammatory response to cardiopulmonary bypass. I can't present a talk on transposition of the great arteries and postoperative management without showing this slide. Peter Lawson actually made this slide. This I'm sure everybody has seen Gil's landmark work from the mid-90s when he was in Boston. This is a hemodynamic profile in an arterial switch subgroup. I think what's very important to note here is that there's a predictable and reproducible drop in the cardiac index on patients. That's the yellow line that dips down between the 9 and 12-hour mark, but is time limited and then comes back up. But I think one of the other things that we forget about Gil's work and what he's shown here is that there's also an increase, a concurrent increase in both the systemic vascular resistance and the pulmonary vascular resistance that happens at the same time. And a lot of what we do in the ICU is not just managing this drop in cardiac index and this low output state, but really mitigating the effects of a rise in pulmonary vascular resistance and systemic vascular resistance. So I like this slide because it shows all three of those variables on the same slide. And as Gil said earlier, what I like is seeing the heart rate in a patient come down as the cardiac output increases, and the heart rate is seen in red just below that dotted line. So I think this is a powerful slide that we keep in the back of our heads every day. Low cardiac output state is probably the most important thing that we see, as was shown in the last slide. The etiology is multifactorial: bypass and ischemic time, myocardial protection, manipulation of the coronary artery, and potential injury to the coronary arteries. And it's manifested by pretty reproducible clinical signs and symptoms, which of hypotension, elevation in left atrial pressure, and elevation in lactate, decreased urine output, tachycardia. Treatment is really aimed at correcting the abnormalities that you saw in Gil's graph. So inotropes, augmenting cardiac output with inotropes. We tend to use the low dose epinephrine infusion for the majority of patients following an arterial switch operation. They'll almost always come up on a 0.02 to 0.05 micrograms per kilogram per kilo dose, or per minute, sorry, dose of epinephrine. Dopamine we use less frequently in our ICU, but it's another inotrope that's commonly used. Vasoactive drugs such as milrinone and sodium nitroprusside are often used to lower systemic vascular resistance in that predictable fashion. If you remember from the slide where the SVR will go up early after surgery. And if necessary, it's not common, but if necessary, if the pulmonary vascular resistance is a problem in our postoperative patients, we're very quick to use supplemental oxygen through the ventilator or inhaled nitric oxide if necessary. The basic principles still apply here, minimizing oxygen consumption, which was talked about earlier this morning. I think I stress to our faculty and trainees the rapid detection and early reintervention on any residual anatomic lesions. We're very lucky to have an excellent imaging group. We get good epicardial imaging coming out of the operating room, so we often know what we're dealing with. But if you're not sure, an early cardiac catheterization, there's still a bit of dogma that going to the catheterization lab early is risky. We have good data showing that it almost always finds an intervenable lesion, whether that's a coronary artery obstruction, a residual intracardiac shunt, or some outflow tract obstruction that could be dealt with safely in the operating room. So if you don't know and you're not following the course that you expect, investigate. Start with non-invasive imaging and move on to early cardiac catheterization. And if things aren't getting better, then we will use ECMO. We'll use mechanical support of the circulation prior to an event, prior to a cardiac arrest, ideally, and then go sort out what's causing the underlying problem. Conduction disorders are common, as we saw from the STS data. Ectopic junctional rhythm is probably the most common thing that we see. It occurs in about 20% of our patients. We tend to use procainamide to treat. Most centers, I believe, in the United States are using amiodarone. The first steps prior to pharmacologic management are electrolyte, fixing the electrolytes, cooling down the patient, and pacing in an AAI mode. Dexmedetomidine has taken on an important role as well to slow the heart rate down and allow for AAI pacing, while at the same time providing a good sedative effect. One really important take-home point here too is AV nodal conduction abnormalities. Any conduction abnormality along the AV nodal pathway, when the surgeon did not close the DSD, when there's really no reason to have that, has to be considered ischemia until you prove otherwise. So if you're seeing an AV nodal conduction abnormality, heart block, and an arterial switch with an intact ventricular septum, that has to be investigated pretty rapidly as ischemia until you prove that it's not. And any type of ventricular arrhythmia is ischemia until proven otherwise. And that's something that we'll act on very, very quickly. Other considerations, ventilation, no surprises here, is maintaining normal blood gas parameters. Many of these patients will go into the operating room in a reasonable amount of heart failure, and we have to select ventilator strategies to compensate for that. If there is pulmonary hypertension, we talked about using INO. There's ventilator strategies that we use to treat that as well. The sedation and analgesia, we tend to use narcotics and non-opioid adjuncts such as Tylenol. Dexmedetomidine is another drug that we're using more and more commonly, and neuromuscular blockade is the need for neuromuscular blockade is rare, but is used in cases where there's arrhythmia that the patient needs to be cooled and paced, and it's used in patients that have a profound low output state to reduce their oxygen consumption. We do continuous EEG in all neonates following bypass as of late, and we monitor for seizures that are subclinical. And I think that fluid management and nutrition is as we alluded to earlier, is critical. Early diuresis of these patients. Again, if the patient went in with a lot of lung water, getting that fluid off and improving their lung compliance on the ventilator is critical. And starting enteral feeds as early as possible is essential. So in summary, know your anatomy as an intensivist and a cardiologist. Know your anatomy before the patient goes into the operating room so you can anticipate problems in the postoperative period. Postoperative care starts at birth. Communicate with your surgeon, your anesthesia team. It is incredibly essential to have a good relationship with the entire team, anesthesia, the surgical group, and the nursing team. And it does improve outcomes and impact the care of our patients. Anticipate and manage the low output state. It is completely predictable, and staying one step ahead of our patients is really the key to what we can provide as cardiologists in an intensive care unit environment. And investigate early any unexpected postoperative course. Don't let a patient sit there and either have an event, cardiac arrest, end up on ECMO, or end up on ECMO and then not quickly investigate with cardiac catheterization what the underlying lesion is. So with that, I just want to say thank you. As many of us have said, that I've had the incredible opportunity to build my career on the shoulders of giants, Peter Lang, Peter Lawson, Gil Wernovsky, and Dave Wessel from the medical side, and countless surgeons that have come through our program and that are still at our program that I've had the honor to work with. And being part of a panel like this is just another opportunity for me to learn from the really tremendous work of the people who came before me. So thank you.
Gil.
Grace, Grace and Sasha, you're going to wrap this and announce the next ones. And
Yes, Grace.
Yeah. So we thank everybody. So it's been a very, very nice to have you here, and we wanted to invite you for our next webinar. It's going to be on the next Thursday. We are going to talk about cardiac anesthesia, and it's important for you to know this is not for anesthesiologists only. So for all the multidisciplinary team who deals with congenital heart defect patients, it's going to be a very interesting and we hope in the same level of the last webinars. And thank you, everybody. Please follow us on social media. And that's it. Thank you very, very much. This webinar was amazing. Thank you.
Gil.
And we are going to leave a little bit open this webinar if you want to read the chat and the question and answers, because it's a very rich material, because there was a lot of discussion that happened on the chat and on the question and answers. So we are going to leave this meeting open a little bit more so you can read there and learn a little bit more and see what people from all around the world had shared. Thank you, guys.
thank you, faculty. Really appreciate everybody being here. We'll look forward to the next one. Everybody stay safe, okay?
Yes.
The same to you. Thank you.
Excellent time.
Thank you, guys.
Bye-bye.
Thank you, everybody.